Now, the question is like the speaker may not have enough time to finish all the talk. If that's the case, please refrain from asking questions. You can ask questions later on during the what you call tumor board, the breakout session. One important thing is that during the tumor board, we would like the participant to participate in the discussion. That way we can go back and forth with what we have. And what we would like to do is present a couple of cases as a sample. And then during the breakout sections, what we like to do is if you have any interesting cases that are of educational value, some controversy or some advice, we would like you to present those cases. You don't have to have slides or anything. You can just stand up and talk. And we will try to discuss that matter and see whether we can help out with the scenario. During the tumor board, the participant will be asked a couple of these multiple choices questions. Those questions are not to test your knowledge, but it is basically trying to assess what are the popular treatment here and how the staging and everything got work here. So you will be giving the clicker, and I'm sure you have a sample of a clicker. And these are the clicker, and they will have a choice, and you just select the number that you think that is going to be the right one or whatever you think appropriate. But it's very important that you turn the clickers when you leave the conference, because we have it in what you call itemized numbers, so we have to be careful with that. There is also an evaluation form in the back, and please make sure when you leave to enter the evaluation form and enter the question and answer, because that way we will have the clue of what will be appropriate for the next section. So let's to begin. I would like to welcome Dr. T.T.G., who is the chairman of the Finland Group of Hospitals, to just give you the little bit of introduction. Dr. T.T.G. Mic connected.
Distinguished guests and participants, colleagues, ladies and gentlemen, good morning. Minglawa Shin. It's a great pleasure and honor for me to give my warmest welcome and sincere thanks to all of you who have come together here today from various countries for your cooperation, which has enabled us to conduct a highly fruitful ASCO Multidisciplinary Cancer Management course here in Myanmar. First of all, on behalf of Finland Group of Hospitals, I would like to thank ASCO for conducting ASCO MCMC in Myanmar, and all the speakers for taking your time off from your busy schedule to share your experience and expertise at this conference. I also wish to thank Professor Newton, Professor Rimmer, and Professor Soal for devoting your time and effort on coordinating this great event. And I would like to express my gratitude to co-sponsor Uong Ko-win and Donandan Thuy, the chair and vice chair of Kamoza Group of Companies. It's an honor for us to welcome all the participants, and I believe this ASCO MCMC will bring fruitful outcomes regarding treatments and care for cancer patients, and I'm sure this conference will give great benefits to all the participants as well as our people. Thank you.
Next, I'd like to invite Dr. Rimmer to give some introduction remarks on this meeting and this gathering. Dr. Rimmer is the president of the Myanmar Medical Association, and he's a professor in hematology. Please come.
Thank you. Good morning, ladies and gentlemen. It gives me great pleasure to have the opportunity to address you this morning at the ASCO Multidisciplinary Cancer Management course, jointly organized by the Oncology Society of the Myanmar Medical Association and ASCO International, and sponsored by the Penlong Group of Hospitals. I believe this is the first time ASCO International has come to Myanmar to hold such a course, and I would like to welcome all the members of the ASCO team and thank them all for making this cancer management course possible. Today, indeed, is a landmark occasion for all doctors caring for cancer patients in Myanmar. ASCO, or the American Society of Clinical Oncology, is a professional organization representing physicians of all oncology subspecialties who care for people with cancer, founded in 1964, with worldwide membership exceeding 30,000, all united by their common concern for the patient with cancer. Today, ASCO is a world-renowned organization which holds many conferences on cancer, publishes journals, facilitates the education of doctors involved in cancer care, and collaborates with medical and research organizations worldwide. Through ASCO International, it has held many cancer management courses like this one in many developing countries. ASCO has been highly successful in advancing and disseminating medical knowledge and contributing greatly to the improved diagnosis, treatment, well-being, and longevity of hundreds and thousands of fellow citizens with neoplastic diseases, and to aid in the prevention of many others. We are indeed very proud and honored to have with us today representatives of such an esteemed organization. The Myanmar Medical Association was founded in 1949. It is a voluntary, non-profit, professional organization, and the main objective is to promote high standards of medical practice and ethics in Myanmar. It is an umbrella organization for many specialty societies, including the Oncology Society, and its main activities are educational, and every year we hold many conferences and meetings with international participation. We also organize CME courses, talks, and lectures throughout the country. In recent times, we have also been taking part in public health programs like tuberculosis, malaria, sexual and reproductive health, and youth program. Cancer is a very important disease for all of us. In Myanmar, the leading causes of death are still infections like malaria, tuberculosis, and HIV/AIDS. However, cancer is catching up very quickly, and as the prevalence of infectious diseases are coming down, non-communicable diseases will become the leading causes of death in the near future. And among the non-communicable diseases, cancers rank second after cardiovascular diseases at the present. 11% of deaths in Myanmar are due to cancer, and death rates from cancer in Myanmar, men and women, stand third and fifth highest in the Southeast Asia region. Cancer-related deaths in developing countries are expected to double within 2 years. When we were medical students, and that was several decades ago, the diagnosis of cancer would mean, for many patients, an incurable condition, pain, suffering, catastrophic costs, and miserable death. That perception still exists for many people in this country. Science, however, has made considerable advances. Today, we understand the biology of cancers a lot better, and there are many new treatment modalities. However, advances also mean more sophisticated equipment are necessary and more advanced diagnostic tests required. Many new treatment regimens have become available. This means oncologists, pathologists, radiologists, and others would also need to be trained in modern methods. Nurses, technicians, and other paramedical staff are also required as team members. This means a lot of investment in the field of cancer management, human as well as material resources. In the economic hardship Myanmar has experienced during the past 2 decades, however, we have not been able to keep pace with all the advances, and at the same time we have had more cancer cases in hospitals all over the country. Physicians have had to manage patients with many limitations. However, they have done their utmost in caring for cancer patients with whatever they have. And I would like to salute all those doctors and nurses who stood by their patients during these difficult years and cared for them. For the practice of medicine is not about Not always about curing, especially in cancer management, but about caring most of all. Now times have changed. The country has opened up. There have been more investments in the healthcare sector, both in the public and private sectors. Doctors are now free to travel and develop contacts and make networks and exchanges with international agencies. It is an opportune time to catch up and to try to provide the best care for patients with cancer. In the past, many patients who can afford travel to neighboring countries in an effort to obtain the best possible care, and most of these patients were cancer patients. Now, with recent developments and improvements in the healthcare sector, all patients will have a chance to get the best possible care inside the country. And I would especially like to thank all the faculty members of the ASCO International team in helping us to provide the best care for all patients with cancer in Myanmar. Desperation is what most cancer patients develop, and hope is what they look for. But hope alone is not enough. And I'm sure all of you today will be able to give not only hope, but the best possible care for all patients with cancer. I would especially like to thank the organizations of this multidisciplinary cancer management course, and especially to Dr. Mutan, whom I knew many, many years ago as a very bright elder brother, to Professor Dr. So Aung, my colleague, and especially to Dr. Zoto and Dr. Tete Ji. Thank you very much, all of you. Thank you again.
Thank you, Dr. Rimra. I think the next person that I would like to invite is Dr. Soang. He's the president of the Myanmar Oncology Society, and as you well know, he is well-known oncologist here in Myanmar. Dr. Soang.
Thank you, Professor Mutan, for a very kind introduction. And good morning, our distinguished guests and my colleagues. And first of all, I would like to warmly welcome our faculty member who have come all the way from their home country to us to share their very invaluable knowledge and experience with us today. And we deeply appreciate your support for this MCMC course. And as a result of concerted effort by ASCO and Penong Group of Hospital led by Professor Muta, Dr. Zoton, Dr. Titeji, and MMA, Myanmar Medical Association, and Oncology Society, our dream has come true today. And this is a historical landmark, and this is a very important step, tremendous step forward, and I'm sure this course will provide us with a much-needed boost to implement the very effective multidisciplinary cancer management system in our country. And actually, this concept of multidisciplinary cancer management is not new to us, but the implementation is very disorganized and ineffective in the past. And actually, we started our oncology specialty way back in 1958 when we first established our radiation oncology center in the country. And since then, we have had few more cancer centers in the country, and up until at the present, we have 8 government centers and quite a few private centers. And out of private center, this Penlong Center is the only one which has both radiation and medical oncology facility, and this is a very good one indeed. We have very few cancer centers actually, given the big size of population. We have a population of, we used to have 60 million in the past, but according to the latest census in 2014, we had just about 51 million. And anyway, we only have very few cancer centers, combined private and public, and you can count on your fingers. And these centers have to serve a population of this big size, about 50 to 60 million. You can just imagine the workload. And you can just imagine how high the patient volume is and how heavy the workload is. So it's overwhelmingly difficult. And on the other hand, we have very limited resources, both in terms of human and material resources. And so this multidisciplinary teaching course is very important, especially what I would like to come out from this meeting is resource appropriate guidelines or something like that, so that will be useful for our country to be used. And although despite these limitations and difficulty in our country, we did have some scattered efforts in the past, over the past few years, at organizing these multidisciplinary cancer management meetings and clinics. And for example, we do have regular weekly cancer joint clinic between Oncology Center in the Yangon General Hospital and Facial Maxillary and Oral Medicine Plastic Surgery Department on weekly basis. And we do have monthly regular clinical meetings for each allied specialty where we can present our cases and discuss the management of those cases. And these are not specific for cancer management, and we do not have specific joint cancer clinic at the moment. But we did have one when I was in the service, government service, and we did it every other week at the Yangon General Hospital. And then we also did have one gynae oncology multidisciplinary tumor board at the Central Women's Hospital. It was in the past. And for some reason uncountable to me, these were not sustainable. And so what happened is that the patients suffer from lack of these multidisciplinary management causes. And they were and they are deprived of the benefit of this multidisciplinary management. And the patients suffer from lack of cooperation and coordination between pathologists and clinicians, and from lack of coordination and cooperation among the clinicians themselves, and also among the different allied specialty as well. So as you all know, proper diagnosis, pathological diagnosis, proper staging, and proper choice of modality of treatment, and proper sequence of treatment is very important. They are very important components of multidisciplinary management, and this can make the difference between life and death when it comes to cancer management. So this is especially true in today's era of personalized medicine. So it is high time that we join our hands together, we scientists join our hands together and implement, with the support of ASCO and international organization, implement an effective multidisciplinary management clinics and meetings. And I do hope that this MCMC course will go a long way in driving this message home and will in helping us implementing and very effective multidisciplinary management for each and every cancer, especially those 3 cancers which we are going to talk about over a couple of days, say breast, say colon, and lung cancer. So I would like to especially thank ASCO and international other experts from different countries who come over here to organize this course. And with this remark, I would like to conclude my presentation of MCMC in Myanmar. Thank you.
Thank you, Dr. Seo. The next, I'd like to invite Mr. Doug Bao, who is the senior director of the International Affairs of American Society of Clinical Oncology, and basically he's responsible for spreading expanding the knowledge all over the world. Doug, would you be glad to come in and give a talk?
Great. Well, is this working? Fantastic. So first of all, I just want to thank, on behalf of ASCO, Dr. Mio, Dr. Su Ong, colleagues, the partner organizations to pull together this course. Thank you so much for inviting ASCO. It's really our honor and privilege to be here and to work with all of you to help improve cancer care in Myanmar. Just briefly, I wanted to see if we could do a show of hands. I'm interested to see who is in the audience. So if you are a medical oncologist, can you raise your hand, please? Great. Fantastic. Radiation oncologist, can you raise your hand? Fantastic. Surgeons, can you raise your hand? Great. Nurses, can you raise your hand? Excellent. Fantastic. Pathologists, do we have any pathologists? Excellent. Now I'm going to start offending groups because I can't think of any registries, cancer registries. Yeah. Well, I think that gives a very good sense of the multidisciplinary group that we have here. And my advice to you as you go through the next 2 days is to think about what changes you can make in your practice as you listen to the talks. Change is not always easy. It can be difficult, but if you start with small changes and then build from there, it will be amazing what you can do in a short time. So let me just very briefly, I know we're short on time, go through a little bit of what ASCO and ASCO International is as some background. So ASCO is today an international organization. A third of our membership is from outside the United States, and actually a majority of the attendees that come to our meetings come from outside the United States. So we take very seriously our responsibility, excuse me. So here you can see, it's a little hard to see, but a map. The dark colors are where we have members around the world. And we take very seriously this global responsibility to work with our members around the world to improve cancer care. I hope that those of you who are not currently ASCO members would consider joining ASCO. A few opportunities here to bear in mind. One is that if you are still receiving your training on oncology, you can join ASCO for free. And so this is a way to join the community at no cost and to get to know ASCO a little bit better and pursue those opportunities. We also have a reduced membership category for countries like Myanmar, and I can give you more information about that during the break. I think for Myanmar it may be $175 a year to join ASCO in this category. So just very briefly, a few years ago ASCO launched ASCO International, and this was really a recognition of the rise of cancer in countries like Myanmar, low and middle income countries that are seeing a dramatic shift in the disease burden. And the strategy here is to link up ASCO members in countries like Myanmar with ASCO members outside of the country to share knowledge through courses like this and other programs, which I will describe very briefly. So ASCO International really has 3 pillars. One is to improve quality of care. We also aim to accelerate innovation and research through research grants and other opportunities, and also to support professional development of the oncology community. So we improve quality of care through training courses like this. We have a few other programs which I'll touch on very briefly. So we have training courses, palliative care, cancer prevention. We're launching a new course this year to train primary care providers in aspects of cancer control, covering early detection, cancer prevention, other topics that they can put into their practice. We have a program called the International Cancer Corps, which sends ASCO members to specific hospitals in low and middle income countries to do a comprehensive development of their oncology capacity. And the Best of ASCO program shares highlights of the ASCO annual meeting in different countries around the world. In terms of supporting research, we offer a training workshop on research skills, which certainly we can explore whether there's interest in Myanmar for such a workshop. And we also provide research grants to help support research in countries like Myanmar. And in fact, through this program, the Innovation Grants Program, we're funding Dr. Theda here in Myanmar, who is doing cervical cancer research, and as well as other investigators in other low and middle income countries. This is a program through our Conquer Cancer Foundation, and we're very pleased and privileged to have the chair of the foundation here with us today, Dr. Penley. He'll be speaking later on today. And I encourage you to talk to me and talk to Dr. Penley about opportunities through the foundation to support your research ideas. Here are some other Conquer Cancer Foundation research awards and opportunities. And then finally, in professional development, we have the IDEA Award, which is for younger oncologists who are looking for mentoring opportunities and ways to visit, to participate in the ASCO annual meeting. So we have just concluded the IDEA round this year, but we will be starting up again next year. And those of you who are in the earlier stages of your oncology careers, I encourage you very much to consider this, this award. And the Life Fellowship provides an opportunity for you to spend time with your mentor at their institution in the United States or Canada for a longer duration, for a year. There are very few of these. We do one or two of these awards each year, so it's very competitive, but it's a fantastic opportunity. So just finally, encourage you at the end of the course to complete the evaluation form that helps us to improve these courses and understand what is working and what is not working. So please provide your feedback. And that's it. There is my contact information. And please talk to me during the breaks. Send me an email. I'd be happy to give you more information about ASCO membership and other opportunities through ASCO International. So thank you very much, and look forward to the next few days. Thank you.
Thanks, Doug. Appreciate that. Okay, now I think we can just start going to the main topics. My name is Myo That. I'm basically from the, I worked as an attending physician at the Baltimore VA Medical Center, and also as a assistant clinical professor of medicine at the University of Maryland Greenbaum Cancer Center. The topic that I'd like to start today is about screening colorectal cancer. I'm sure a lot of people know about it, but I thought it would be nice to refresh it. As you well know, cancer accounts for 1 in every 8 deaths in the world, and in 2012, we estimated 14.1 million cases of cancer diagnosed and 8.2 million deaths. And we expect that to increase significantly in the number at an alarming pace. And if you look at it, more than 60% of the cases occurs in the low and middle income countries. And part of it is because of aging population, and part of it is adoption by these third world countries into these Western lifestyle, the bad lifestyle, as you well know, having poor diet, increased obesity, physical inactivity, and smoking. And that basically causes the increase in the cancer in these third world countries, particularly since they're not doing any prevention or screening or increased cancer awareness. On the other hand, in the United States, in the Western country, we found that we have significant progress in colorectal cancer. The 5-year survival rate, in fact, has definitely increased, increased from like 46% to 48% in 1975, all the way to 2009. If you look at it, it has significantly increased to 66%. This is the same is true with the mortality. The cancer mortality has dropped down to 29 per 100,000, all the way to 16 per 100,000. And this is primarily because of increased awareness of cancer, and also because of the proper screening and follow-up. As you well know, the progress of cancer, starting from normal mucosa all the way to cancer, is relatively straightforward. Starting with normal cells, increased proliferation of hyperplasia, to small adenoma, to large adenoma, and finally to cancer. And all these steps are basically caused by mutation in these genes. And we are finding more and more genes in that regard. And so the interesting thing is it takes about 10 years from the normal to develop into cancer. So that's one of the reasons why we recommend colonoscopy once in every 10 years for a normal individual. However, it is not true in HNPCC or hereditary non-polyposis coli, where it can develop within 2 to 3 years. So in these people, you need to do colonoscopy every 2 to 3 years. Most of colorectal cancer, however, is sporadic. It occurs as a random mutation of the genes and chromosome, and only 15% is caused by hereditary colorectal cancer. And what are the risk factors? Naturally, personal risk is the most important one. If you have an increase in, if you have colorectal cancer, there's a significant increase. You want to develop another one. If you have a family history, like a first-degree relative who developed cancer, then the chance of you getting another cancer is higher. Diabetes is very interesting because it increases insulin, and as a result, it increases the insulin-like growth factor that stimulates carcinogenesis. Alcohol and smoking, as you well know, are not good at all because they increase colorectal cancer. Diet, particularly red meat and low-fiber diet and low-fruit diets are very increase in causing cancer because it releases nitrosamine in the body system. We have found now that obesity and physical inactivity are very important because there is significant increase in not just colorectal cancer, but also in other cancers. This is a graph, the study done by one of the large cooperative group that looks at the body mass index and relapse progression-free survival or the increase in survival. If you look at the green graph, you notice that it is caused by underweight people. On the other hand, if you look at the next graph, you find that it occurs in obese patients. So naturally, having overweight is not really good at all. And the same is true with physical activity. And people who do regular exercises have better survival than people who are just not doing any exercise at all. Of course, other risk factors include inflammatory bowel cancers. The inflammatory bowel cancers got 40% of them developed in colorectal cancer, and that includes ulcerative colitis and Crohn's. And ulcerative colitis, you have to be aware that it takes about, particularly for 10 years after pancolitis, you have to be started worry about getting cancer. And these people need to be aggressively followed with the periodic colonoscopy, and if there are any dysplasia, they need to be referred to a surgeon for prophylactic colectomy. Crohn's disease, however, is segmental, so you can do a segmental resection based on the changes. And these are other hereditary colorectal cancers. Of course, among them, the most important two are hereditary non-polyposis coli and familial adenomatous polyposis. Hereditary non-polyposis coli cancer, or Lynch syndrome, occurs in about 4 to 10% of the colorectal cancer. It can also cause other cancers like endometrial, biliary, stomach, small bowel, ovaries, and renal pelvis. The lifetime risk for developing is 80% or so, and it's usually caused by mutation in these DNA mismatch repair genes, and particularly MLH1, MSH2, MSH6, and PMS2. And you can identify these by doing immunohistochemical analysis of the mismatch repair proteins or the polymerase chain reaction and for analysis for microsatellite stability. Any of the person who fits into Amsterdam or criteria Bethesda guidelines have to be analyzed for HNPCC. I'm not going to go through those guidelines, but briefly, it's basically if you have a relative that has a cancer at a younger age, then the risk of you getting is very high. The same is true of familial adenomatous coli, and they usually present with multiple coli throughout the colon. And these almost 100% will develop into cancer. And usually it goes from Mendelian autosomal dominant and from the germline mutation of the adenomatous polyposis gene located on the long arm of the chromosome 5. They can also develop other cancers, such as small bowel, papillary, and pancreatic cancer. Of course, you need to screen those people for colorectal cancer. And what are the screening too? We have fecal gut blood, flexible sigmoidoscopy, CT colonography, and colonoscopy. I'm not including barium enema since we are not using anymore for the screening process. Fecal gut blood testing is low cost, very simple and very cheap, and it can be done at home or in the physician's office. But it requires 3 separate stool specimens. You can't do 3 tests on 1 specimen. That's not really 3 tests, but you really need to have a 3 separate stool specimen. The problem is it can be affected by diet, whatever that the individual eats, or also aspirin. Particularly, you have to be off aspirin for at least 8 to 10 days before you can do the test. The sensitivity is not that high either. It's only about 33 to 50%. The newer tests, such as fecal immunochemical tests or the immunochemical fecal gut blood test, has sensitivity increased to 60 to 80%. Once they become positive, naturally, you need to go with further evaluation. Still, for DNA testing is a new test that got approved not too long ago, and it looks into the DNA mutation of all these stools, all the stool specimen. The advantage is that you don't need to have special preparation, and you don't have to have any diet or medical restriction. And the same is true, it can be done at home or in the physician's office. However, my personal thinking is that it is relatively expensive at this time, and I hope down the line they will come down in price. CT colonography naturally is a new radiological technique, and it's the radiologists claim that it can detect 90% of polyps that are greater than 10 millimeter, but on the other hand, the accuracy and sensitivity drop down when it's smaller than 6 millimeter, and it misses the flat polyps. The problem, it requires preparation and it increases radiation exposure. Here are the sample of the CT colonography. This is an adenoma with a polyp, and the same is true with here. I'm not sure whether you can see it clearly, but this is the new test that we have to start thinking about. Flexible proctosigmoidoscopy reduced mortality by 60% on the right, in the left-sided colon. And you can do it in the general physician office. You don't have to go to a colonoscopics or anything, because it doesn't really need sedation or special preparation. On the other hand, it can miss 30% of the right-sided colon cancer. Colonoscopy, of course, is the mainstay in screening procedure because it can reduce 53 to 72% of the colorectal cancer, and it can reduce mortality. There are serious complications like perforation or bleeding, but on the other hand, they are not that common. It's only about 3 to 5 per 1,000 colonoscopies. The interesting thing about colonoscopy, however, it also depends on how rapid the colonoscopics try to withdraw the colonoscopy. If the colonoscopic try to withdraw the colonoscopy less than 6 minutes, it only detects about 11.8% of colorectal cancer, of any neoplasia, and only 2.6% of advanced adenoma. But if the colonoscopist is thorough and deliberate and be slow in moving, taking about more than 6 minutes, it increases to 20.3% and 6.4%. So I think if you go for colonoscopy screening, we just need to talk to these colonoscopists not to move the colonoscopy and not to do it in a hurry, and just they should take deliberate time. Of course, what the benefit of screening, it reduces the colorectal cancer mortality by detecting cancer at an early curable stage, and also detect and remove polyps before they become cancerous. So who should have a screening procedure? In a normal individual, if you're 50 years old, then there's no family history, no history of adenoma or CRC, no history of inflammatory disease. You can do annual stool for a gut blood and also proctosomnography every 5 years and colonoscopy every 10 years. For whatever reason, you can't do a colonoscopy, you can do CT colonography every 5 years. But I'm still skeptical about that test, though. Personal history, if you do have personal history of adenomatous polyp, then you have increased risk of developing colon cancer. So if you have a low risk adenomatous polyp, which is like 2 centimeters or less, or only 1 or 2, you can do the colonoscopy within 5 years. But if you have multiple polyps, then you need to do colonoscopies within 3 years. The same is true if you have family history. The first relative with age who is less than 60 years old, then you need to do colonoscopy at the age of 40, or 10 years before the earliest diagnosis of colorectal cancer. That means if your first-degree relative has a colon cancer at age 40, then you should be doing it beginning at age 30. But on the other hand, if you have older than 60 years old, you can do like a normal colonoscopy at the normal period. On the other hand, and the same is true with personal history of inflammatory bowel disease. If you have ulcerative colitis, colonoscopy should be done 8 to 10 years after onset of symptoms of colitis. And it's important that they need to do biopsy of the skin, what you call the mucosa, and then after that you do colonoscopy every 1 to 2 years. And as soon as you see any changes in dysplasia, hyperplasia, you have to be calling the surgical consult. And then, of course, if you yourself have a colon cancer, depending on the stage, if you have a high stage, you have to do HNP and TE level every 3 months, 3 to 6 months for 2 years, then yearly for 6 months for a total of 5 years. And then you have to do CT scan of the chest and abdomen annually for up to 5 years, and colonoscopy in 1 year. And then if there's no change, if you don't notice any polyps or so, then repeat it in 3 years, and then 5 years. On the other hand, if you keep seeing the polyps, then you need to repeat that. Of course, we like to prevent it from having the disease, and what are the things that we should do to prevent? And the thing is that if you have low red meat or processed food, that's the best way to prevent. The diet is much better. The same is true with abstaining from drinking alcohol or smoking. And also, of course, the most important thing is to maintain the body weight and to do regular exercise. This is American Cancer Society guidelines score in risks of cancer. What it means that they follow about 65,000 women for 12 and a half years. And if these people follow strict guidelines such as maintaining body weight, regular exercise, and abstaining from alcohol and smoking, it reduces any cancer by 17%, and breast cancer by 22%, and colorectal cancer by 52%. So you can really reduce the incidence of cancer if you really are aware of the disease. And one of the things that has been popular recently, has been popular, is aspirin, and people use a lot, take aspirin to prevent cancer. But the thing is that it's very interesting. It inhibits prostaglandin peroxidase synthase related pathway. And then the interesting thing is that one study showed that it reduces colorectal cancer by 50% in individuals who have high levels of 15-hydroxyprostaglandin dehydrogenase. Unfortunately, we can't do the test on every individual. Aspirin, unfortunately, all the studies have been looking at with high dose, more than 300 milligrams, and then naturally that's a problem because we do see some side effects like bleeding. So currently we don't recommend to take it regularly because we don't really know the dose and the duration that we need to do to find out how effective that is. The same is true with NSAID or COX inhibitor. We know that Sulindac and celecoxib reduces the adenomas in familial adenomatous polyposis. However, we don't really know. We have the same problem of finding the dose, duration, and the drug that we need to take. And of course, we have to be concerned about the side effects of the disease, such as GI irritation, bleeding, and renal toxicity. So there are some ongoing studies. As long as we don't have the conclusive data, we should not be taking that to prevent the disease. Statins have become popular recently, and there are very interesting studies going on because it inhibits cell proliferation and apoptosis and inhibit angiogenesis in addition to the regular and lipid-lowering effect. The only problem with statin is that the results are not conclusive, but they have found that using statin after diagnosis of colorectal, it may be beneficial. Currently, a large cooperative trial is looking into this and recruiting patients, but like I said, until we get more data out of it, we shouldn't be taking statin to just prevent colorectal cancer. Metformin, the anti-diabetic diet, anti-diabetic medication is also becoming very interesting because it has a direct effect by inhibiting adenosine monophosphate kinase, which affect we call it mTOR pathway, and indirectly it also reduces the insulin. That way we also reduce insulin-like growth factors to prevent the disease. And interesting that in diabetic patients, they claim that it reduces the incidence of mortality of colorectal, breast, and pancreatic and hepatocellular carcinoma. But the problem is the studies are all retrospective. It's not really thoroughly organized study, and so we don't have a real conclusive data. So at this present time, with the same thing, we don't recommend taking them. And of course, there are lots of people who like to take vitamins, and vitamin D is particularly interesting because they found increased cancer in countries that are away from the equator. But the problem is they are primarily observational, and the role of vitamin D supplementation is not thoroughly studied. Selenium naturally is one other drug that people are very, I think, popular and taking regularly all the time. The only problem is that they did have a recent meta-analysis looking at, I think, 8,000 patients, and they found that selenium doesn't really reduce the colorectal cancer. Of course, the other vitamins such as vitamin A, vitamin E, and beta-carotene, we have to be concerned because there are studies that show that they increase the cancer incidence of lung, stomach, and prostate. So we have to weigh those consequences before we think about taking them. And of course, what do we do basically is the most important thing to me is that you maintain the body weight and doing regular physical exercise. Thank you for that. And for next discussion, we'd like to have Dr. Tan to discuss on the pathology of colorectal cancer. As you know, Dr. Tan is a professor at the Singapore General Hospital and the Department of Pathology. She's also a professor of the Duke National University of Singapore. And she has published many papers, and I'm hoping that she can present all this knowledge to us. And this is...
Causes and pathogenesis, we've heard earlier: environmental, genetic, epithelial polyps, inflammatory bowel disease, and irradiation, for instance, in patients who have irradiation for previous cervical cancers. So I'll dive straight into the gross pathology of colorectal cancers. About 50% of the cancers occur in the rectosigmoid area, and there has been an apparent shift to the proximal colon in recent decades. Right-sided cancers tend to be more frequent in the elderly, in the black population, and in patients with diverticular disease. Multicentricity is detected in between 3 to 6% of cases, and macroscopically, colorectal cancers can be polypoidal, ulcerative, and fungating. There is a good correlation between the gross and microscopic tumor margins. Cut sections show grayish-white appearances. Mucinous tumors are gelatinous and glary. And as a pathologist, there are important gross features to note when we are handling a colectomy specimen, namely the depth of invasion of the wall of the bowel, the presence, if any, of vascular invasion, and this is probably more well detected on microscopy, and a look and evaluation at the appearance of the rest of the colon or rectum. So this is a part of a colectomy specimen, and you can appreciate a relatively ulcerated and slightly fungating tumor that occupies the entire circumference of the bowel wall. And in this example, you have a polypoidal mushroom-like tumor that protrudes into the lumen of the colon. And in this example, you have a tumor that is centrally ulcerated with rolled edges that occupies part of the wall of the large bowel. And this is a slice through the tumor. And here you will notice the whitish-gray appearance of the tumor, and it invades through the entire colonic wall into the pericolic fat. And in this particular picture over here, you can see that the tumor has only extended into the muscularis propria. So it's important for pathologists to slice through the tumor carefully and to determine the deepest extent or depth of invasion, as if you did not slice through this portion, you might just erroneously conclude that the tumor invasion is only into the muscularis propria, whereas in fact it has gone out of the bowel wall into the pericolic fat. Microscopically, most colorectal carcinomas tend to be well to moderately differentiated adenocarcinomas. There can be a stromal reaction with variable lymphocytic infiltrates. The tumor surface may be papillary or villous, and as mentioned earlier, it can invade into all layers of the bowel, and perineural as well as lymphovascular invasion can also be seen. So this is a typical appearance of a moderately differentiated adenocarcinoma of the colon, in which we have confluent glands and some papillary structures that are formed by cells with stratified hyperchromatic nuclei and with brisk mitotic activity, and this is seen within a desmoplastic stromal reaction with accompanying inflammation. Here we have a full thickness section of the bowel wall, and you can notice that the tumor extends throughout the bowel from the submucosa over here, effacing the muscularis propria and extending into the pericolic fat that invokes a desmoplastic fibrous reaction. And this is a nerve in which there is intraneural invasion by malignant glands, and this is lymphovascular invasion, in which there are tumor cells represented by these signet ring cells lying within a lymphovascular space. In terms of histochemistry and immunohistochemistry, most colorectal adenocarcinomas will demonstrate mucin positivity using the mucicarmine histochemical stain. Additionally, on immunohistochemistry, there can be the positive reaction for these antibodies to antigens of MUC1, MUC3, MUC2, and MUC1-3. Immunohistochemistry, there is usually a profile of cytokeratin 20 positivity and cytokeratin 7 negativity in colorectal cancers. And this is very useful in terms of distinguishing it from lung or ovarian cancers, which show an opposite profile. In other words, lung and ovarian cancers will be cytokeratin negative and cytokeratin 20 negative and cytokeratin 7 positive. There is also positive reactivity in colorectal cancers for CEA, CDX2, as well as VILIN. So this is an example of an adenocarcinoma that was detected in a lung biopsy, and we concluded that it was a metastatic colorectal carcinoma to the lung, not only because of its morphological appearances that resemble a primary colorectal carcinoma, but also because of the immunohistochemical support that we got with CDX positivity diffusely in the nuclei of the tumor cells and the TTF1 or thyroid transcription factor 1 negativity within the tumor cells. And here you can see the internal positive control of the alveolar lining cells of the lung, as opposed to the negative staining of the tumor cells of the metastasis of the colorectal carcinoma. Molecular genetics has become very important in colorectal carcinoma, and we have discovered the genetic alterations that drive carcinogenesis. And earlier we heard from Dr. Tant about the APC and the mismatch repair genes, which are also mutations responsible for the sporadic colorectal carcinomas. Just a few words about the DNA mismatch repair deficiencies that result in microsatellite instability. It constitutes about 15% of the cases, and it's usually associated with the hereditary non-polyposis colorectal cancers, right-sided in location, cancers arising from serrated polyps. And these cancers pathologically tend to be mucinous, poorly differentiated, have a prominent host response, have circumscribed growth patterns, and be right-sided. And this is what we immunohistochemically see as a pathologist when we carry out immunostains for the DNA mismatch repair proteins. So this is MLH1, and you can see the tumor over here showing positive nuclear staining for MLH1. This is MSH2, which also demonstrates positive nuclear staining in the tumor. MSH6, similarly with positive staining, and PMS2 with nuclear staining of the colorectal cancer, indicating that there is no abnormality in these DNA mismatch repair proteins. Other mutations in the BRAF, the PIK3, and the beta-catenin genes. And there are also mutations in tumor suppressor genes for P53, APC, and these variety of other genes as well. From the pathologist's point of view, apart from the usual adenocarcinomas that we encounter, there can be other microscopic types such as mucinous, cygnet, micropapillary, basaloid clear cell, and so on. So there's a host of different microscopic patterns, but they tend to be much rarer than the usual conventional adenocarcinomas that we encounter. So this is just an example of one of the less frequently encountered subtypes of colorectal cancer, and this is a signet ring adenocarcinoma, and you know why it's called signet ring, because of the appearance of the cells showing this peripherally compressed nuclei and this cytoplasmic vacuole or mucin that pushes the nucleus to its side. The diagnosis of a colorectal carcinoma is accomplished using a biopsy. And a biopsy that is positive should always be obtained prior to radical surgery for colorectal cancer. These biopsies are obtained from multiple areas, particularly in large lesions, so that you get a better representation. And it's always very important to have close communication between the pathologist the endoscopist and the surgeon. In other words, it's a multidisciplinary type of effort to make the diagnosis as well as to treat the colorectal cancers. And an intact biopsy of adequate size and depth with proper orientation of the specimen is very important. So just a few words about staging. Staging of colorectal cancers have evolved over the years. It started off with a Duke system, which is three-tiered, A, B, C, in 1937. It later on, there was the Essler and Collar system in 1954, but now the AJCC UICC system with a T and M classification is the most widely adopted. So here we have the TMM staging for colorectal carcinoma, and just to look at the T stage over here, TIS is when the tumor is confined to the mucosa, carcinoma in situ. T1 into the submucosa, T2 the muscularis propria, T3 into the subserosa, and T4 when it perforates the peritoneum or attaches or invades adjacent organs, and N0 is when there is no nodal metastasis.
To the next speaker. Next speaker is Dr. Michael Chody. He's a very good friend of mine that we knew since he was at his tenure at the Hopkins. He is now the Chief of Department of Surgery, a Division of Surgical Oncology at University of Texas, Southwestern Medical Center. And he is a well-known GI surgeon. His experience in pancreatic cancer and liver cancer has been really renowned all over the world. He has published many papers, and I'm glad that, I'm really excited that he is willing to come and give a talk here. So, Dr. Chody, please come up to the podium. Thank you. You still have to use that thing.
We're using this microphone? Okay. So I'd like to thank all of you. We're going to focus now on continuing the theme of colorectal cancer with the surgical management. Again, I'd like to thank Dr. Mio Thant and the organizers and the wonderful hosts for our visit here, and to thank ASCO for hosting this outstanding program. So here are my disclosures. So first, as we heard about, colorectal cancer is a big problem. It's one of the most common malignancies worldwide. In the U.S., it's you can see the third most common cancer in men, second in women, and worldwide the incidence is going up. You heard about, we don't know if it's the Western diet or whatnot, but in many developing countries, as liver cancer and head and neck cancer, cervical cancer is going down, the topics we're going to be hearing about breast cancer, in particular colorectal cancer, the incidence and is going up. Here you can see some data from Southeast Asia, and it's interesting. Colorectal cancer is extremely common. If you look at the incidence and the mortality, lung cancer, liver cancer, and colorectal cancer among the most common. So you can see in men, you've heard about third leading mortality. But because it involves both men and women, overall, it's an extremely common malignancy. As you also heard, it's a very preventative. So this is an area where education and multidisciplinary management is important. Here's some data in Southeast Asia. You can see, of course, Myanmar here. Look at some of the GI cancers, oral, esophagus, liver, and so forth. So you can see the incidence of esophageal cancer quite high, liver cancer high, but you can see here, compared to even Thailand, the incidence actually of colorectal cancer is slightly less in Myanmar compared to the other regional countries in this area based on the incidence per 100,000. This is in data for males, but similarly in women. So again, common malignancy. I'm going to focus briefly on an overview of the surgical management, arguably the real mainstay of treatment, really the only curative option, surgical management. So we'll talk about treatment of primary colon cancer, rectal cancer, and even the surgical management of metastatic disease. I don't need to share with this audience the anatomy of the colon and rectum. It's really the large intestine. So the last meter or so of the intestines is the large intestine, the right colon, transverse, descending colon, and the transition to the rectum. The distinction between the rectum and the colon is really more, one is an intra-abdominal structure and one is a pelvic structure. But really, biologically, they're very similar. You'll hear about the treatments are different. The surgical management of rectal cancer is more complicated. The recurrence in the pelvis can be an issue, so that radiation therapy and surgical techniques are very important, in particular with rectal cancer, but also with colon cancer it's important. You've heard already about staging. Colon cancer starts as premalignant polyps in the lining of the mucosa, and as the penetration through the wall of the colon increases, the stage, the T stage, and then spread to lymph nodes, and then stage 4 is metastatic spread. So the idea is earlier detection through the screening methods you heard about is the really way to impact the disease. It's not chemotherapy or even fancier operations. Earlier detection is really the best way to even prevent the disease. Let's talk about management of primary colon cancer. The principles are pretty clear. Removal of the primary tumor with clear margins, lymphadenectomy, that is removal of the regional lymph nodes, and restoration of the organ integrity. So you heard a little bit about the importance of the lymphadenectomy. It's not so much a therapeutic, although that's part of it, it's important for staging. So again, the importance of the lymphadenectomy is both the surgeon's role to do a sufficient lymph node removal, but also it's particularly the pathologist's role to adequately assess the specimen to determine the number of lymph nodes, because that serves as the denominator, if you will. And lymphadenectomies, or lymph node assessment, in which the amount of lymph nodes are assessed is limited, can result in worse outcomes. So this is a very important concept. When one thinks about the surgical management with regard to the lymphadenectomy, this is, of course, the colon. The lymph nodes follow the arterial drainage. So that's why with cancers of the right colon is removed in order to remove the lymph nodes along the lymphatics, along the arterial blood supply. So an adequate resection of the right colon involves removal all the way to the origin of the right colic artery and so forth around. So the concept is pretty straightforward in the surgical removal. So when one thinks of the colon operations, that's why we think these are the typical ones. So if the cancer is in the right colon, right hemicolectomy. Again, the reason so much colon is removed, and it's not so much, but this portion is because this is the lymphatic drainage that necessitates removal of this part of the colon. And then the connection is done between the ileum and the transverse colon. Similarly, left colon cancer, left hemicolectomy. So that's the fairly straightforward. One area is the role of laparoscopic colon resection. And in fact, this is a study, a randomized trial published in the US comparing open to laparoscopic colon surgery. And basically the data shows that oncologically the operation is the same. The number of lymph nodes removed is the same. The complication rates are the same. Somewhat less of a length of stay. So at least in the US and I think worldwide, laparoscopic colon surgery or open colon surgery is equivalent. And I think it depends on the expertise of the surgical team. But more and more, I would say in the US, about 2/3 of straightforward colon resections are now done laparoscopically. What about rectal cancer? More complicated surgically because of the proximity to the anal area, and also more important to have a multidisciplinary approach to rectal cancer. Again, the anatomy is important. So rectal cancer is defined as the last 12 centimeters from the anal verge. The distinction between colon and rectum, increasing local recurrence, use of radiation therapy, the use of neoadjuvant. In colon cancer, we typically do the surgery first and then adjuvant therapy after. In rectal cancer, we'll more often do neoadjuvant radiation and chemotherapy prior to surgery. Very important is the sphincter preservation and the concerns about urinary and sexual dysfunction that make the operations more complex. The names of the surgical operations for rectal cancer are a little different. We typically use the term low anterior resection to mean removal of the rectum and preservation of the anal area with a low reconnection or a coloanal reconnection. So this is called the low anterior resection, and this is the most common operation for rectal cancer. When the cancer is very low, very, very low, involving the anus, then a permanent colostomy is required, so-called abdominoperineal resection. It used to be that in rectal cancer, even 20 years ago, this was the most common operation. Everyone with rectal cancer, APR, abdominoperineal resection. Now, with more modern techniques, we'll talk about, only about 1 out of 20 rectal cancers need this operation. Only extremely low cancers. So we've made major advances in the reduction of the need for colostomy in patients with rectal cancer compared to even decades ago. And this is a very important principle because, of course, patients are very afraid to come to treatment for rectal cancer because they're afraid they're going to have a colostomy. And so it's rare now that we need to do a colostomy. And we'll talk about some of the reasons. And these are the ways we've made progress in the reduction of permanent colostomy. One is very important are the surgical techniques. So there are now stapling devices and methods to do the reconstruction very, very low near the anal sphincter, where in the past it was more challenging to do that. Stapled coloanal reconstruction and local resection in selected cases, transanal removal of early cancers. But also the use of preoperative neoadjuvant chemoradiation therapy can now shrink the cancer that may be against the sphincter and thus allow the ability to remove it with preservation of the anal sphincter. So preoperative chemoradiation therapy has contributed to the reduction in colostomy, as well as improved staging. So with endorectal ultrasound and pelvic MRI scans now, we're better at staging the depth of penetration and thus determine which patients may need neoadjuvant therapy or not. The other important concept in the surgical management of rectal cancer is the adequate wide removal, so-called total mesorectal excision. In the past, there was a lot of surgeons stayed very close to the cancer because they were afraid of damaging the nerves of bladder function, for example, resulting in a high incidence of local recurrence. Where now we understand that a wide, sharp dissection around the cancer to remove the full envelope of lymph nodes significantly reduces the local recurrence rate. So this is a specimen showing the fatty pad around the rectum. So it's not the distal margin that's important, it's the wide removal. In fact, if you look at the old data of the role of radiation therapy, it was often based in surgical techniques that had a very high local recurrence. If you look at the trials, the old NSABP R01, the benefit of radiation therapy in reduction of local recurrence reduced the local recurrence from, let's say, 25% all the way down to 15%, dramatic benefit of radiation therapy. But now the surgical techniques are so much better that we are seeing local recurrence even without radiation therapy in the single digits. So some of you have questioned the role of radiation in the face of improved surgical techniques, at least for the reduction of local recurrence. So very important concept of important surgical techniques to improve outcomes in patients with rectal cancer. One point about there are also ongoing trials now of laparoscopic rectal surgery versus open rectal surgery. This is a trial ongoing now through a cooperative group in the U.S., more controversial as to whether laparoscopic low anterior resection, for example, is comparable to open surgery. But I think depending on the center, some are doing laparoscopic and some are doing open for rectal surgery. So when one talks about the role of chemotherapy, and you'll hear more about this shortly, very important, we use chemotherapy, as I mentioned, in the neoadjuvant setting for rectal cancer, in the adjuvant setting after surgery for colorectal cancer, and of course for advanced disease. When one thinks about the treatment of colon surgery, as I mentioned, typically in most cases, surgery is done first and adjuvant therapy is given after, typically only chemotherapy without radiation therapy, where in rectal cancer, more common at least for stage 2 or stage 3, neoadjuvant chemoradiation with radiation therapy, then surgery, and then more adjuvant chemotherapy. And we'll hear more in more detail in a moment. Finally, let's talk about metastatic disease and the role of surgery. Another important area where we've made significant advances, and I think it's very important to educate the medical community, including the role of surgical therapy for metastatic disease. You'll hear about, we've had significant advances in the role of chemotherapy for advanced disease, with response rates that are now becoming significantly higher and median survivals, even with chemotherapy, that are in the range of more than 2 years. But in patients particularly with limited oligometastatic disease, particularly to the liver, surgical therapy of the liver is something that's being done with increasing frequency with added benefit. So about a third or more of patients with a liver-only metastases, and these patients we should also always consider, when possible, surgical therapy of the metastatic disease. Here's a case of a patient with metastases to the right hemiliver, right lobe of the liver. This is a patient that actually received preoperative chemotherapy and then underwent successful surgical therapy of the metastases in the liver. So it's an area, and many patients, as you'll see, these are the survival rates of metastatic colorectal cancer. If surgery is an option, complete resection, we're seeing 5-year survival rates, even in this older series from Germany, reporting in the 35 to 40% 5-year survival rates. If you look at the more modern series, in fact, we published a decade or more ago, but modern series are now showing 5-year survival rates more than 50%. So arguably better than many primary GI cancers with metastatic disease, in which we're often using chemotherapy combined with surgical therapy of the metastatic disease. One important point in the management of the metastatic disease in the liver is defining resectability. And this can often be difficult. It's really we define it by the location of the metastases relative to the structures within the liver, so that we can get adequate remaining liver. And so this necessitates high quality imaging of the liver, CT scan and MRI scan in selected cases, to assess the relationship of the metastasis to the structure within the liver. And in some cases, PET scan is important to assess, and often even 3D rendering or volume analysis to determine the remaining liver, in order to determine if a patient may have resectable metastases in the liver. In fact, we've become much more aggressive. These are data from Johns Hopkins showing that in the older series, most patients had solitary single metastases you resected. Here you can see 50% had one, and very rare did we remove multiple. Now we're seeing patients 5 or more metastases, or half the patients have 3 or 4 or more metastases. So more and more aggressive now in patients even with multiple metastases. The role of chemotherapy is very important in integration of the metastatic and potentially surgical patient with metastatic disease. And we often will think, so if we think of liver metastases either resectable or unresectable, we will integrate chemotherapy in the resectable patients either before or after removal of the metastatic disease. And in some cases, we call this neoadjuvant or adjuvant. And in some cases, we'll even use chemotherapy in the patient that's unresectable to shrink the cancer and make them now operable. An interesting concept that in fact occurs on occasion. This is a patient you can see with a large metastasis in the right liver, but it's involving the veins here and involving the left structures, unresectable. Chemotherapy, preoperative, conversion, shrinking the cancer, now the tumor is operable. So this is a strategy we'll use in selected cases as well. And this downsizing concept in situations. And then there are other approaches we can do to increase the eligibility. I mentioned we can downsize with chemotherapy. We could also use local regional therapy to downsize. And sometimes we'll grow the remaining liver through stage resections, 2 operations to remove the cancer in the liver, for example. Or sometimes ablation, heat, a microwave or tumor ablation in cases when the cancer is not removable. What are some of the surgical advances? Well, there are a lot of advances surgically. More and more, at least in the US and worldwide, minimally invasive and robotic surgery is done selectively, new imaging tools for both the liver and the colon, and newer devices are being used to be able to more safely do these operations. So the mortality rate now of even major liver surgery for colorectal metastasis is less than 1%. So we've improved significantly in these. Finally, just to touch on the importance of the complexity of the multidisciplinary care, particularly in the stage 4 patients. If one thinks about making treatment decisions, how would you manage this? Very straightforward. Primary colon cancer in the sigmoid colon. This is a patient with 2 metastases in the right liver. It looks resectable. Easy, right? How would you manage this straightforward procedure? Synchronous resectable disease. Well, the options, we can do the colon, then the liver, then chemotherapy. We can start with chemotherapy, then the colon, then the liver, then more chemotherapy. We can do this way with chemotherapy in between. We can actually do the colon and the liver together. We can do this way. And with even sometimes we may do the liver prior to the colon. And with rectal cancer, forget it. We're off the map here with so many choices. So as you know, with many of the oncologists here we work with, it requires communication and a team, not a vertical management, but really thinking about the team optimizing the best strategy for the patient with a goal, optimizing the cure and maximizing the quality of life of the patient. So in summary, surgical management of colorectal cancer, it's complex, but it's very important. It's a common disease, but a major health problem. Surgery is the primary therapy if it's localized. Surgical advances we've talked about, adjuvant and neoadjuvant we've talked about. Aggressive surgical therapy of metastatic disease is improving the survival in these patients. And the key is the multidisciplinary management, early staging, imaging, and combination therapy to really improve the outcomes of our patients. I thank you very much for your time.
Thank you, Dr. Chody. Next speaker will be Dr. Barrowell. He is the Associate Professor of Radiation Oncology at University of Pittsburgh Medical School Center. And as again, he has published many papers, and I'm excited that he is willing to come and give us a talk about the radiation therapy in colorectal cancer.
Okay. So as mentioned by the previous speaker, the role of radiation therapy in colorectal cancer is mainly limited to rectal cancer. There is very limited role of radiation therapy for colon cancer. So my discussion would be mainly for the rectal cancer. So the local recurrence after surgery for rectal cancer for T3 to 4 disease could vary from 15% to 30%. And the reason why the range is because the surgical advancements that significantly reduce the risk of local recurrence. In the past, the risk of local recurrence used to be more close to 30%, but in the era of TME for T3 T4 disease is more close to 15 to 20%. Following surgery, radiation alone improves local regional control, but doesn't impact overall survival. And chemotherapy was initially investigated to see whether we can improve the outcome or not. So some of the earlier data came from the cooperative group where they compared post-op radiation therapy to post-op chemoradiation therapy, both in concurrent and sequential setting. And as you can see, the addition of chemotherapy improved local control, decreased distant mets, and improved survival, thereby establishing chemotherapy as part of the treatment for colorectal cancer, with the addition of radiation therapy improving local control. After the publication of that trial, the standard treatment for post-op treatment for T3, T4, and positive rectal cancer was adjuvant chemotherapy, followed by chemoradiation therapy, followed by adjuvant chemotherapy. But if chemoradiation therapy is required post-op, maybe it is better given pre-op than post-op. The advantage of giving pre-op chemoradiation therapy is it downsizes the disease, so making sphincter sparing surgery possible. You need less dose of radiation therapy probably because there is non-hypoxic environment. You can sterilize the margin, which can improve the likelihood of local control. And the better tumor oxygenation may improve tumor response and may be better tolerated. Some of the earlier study which evaluated pre-operative radiation therapy was the Swedish rectal cancer trial, which was standard operation non-TME versus pre-op radiation therapy followed by the surgery. And what the clinical trial showed that by adding pre-op radiation therapy, we improve local control, improve overall survival, and improve cause-specific survival. This was the only clinical trial in pre-operative setting which showed improvement in survival. But again, the local recurrence rate were higher because the surgery was not TME, which is the standard of care nowadays for rectal cancer. So in the TME era, the first randomized clinical trial where the TME was evaluated in prospective way came from the Dutch group, where about 1,800 patients with T1 to T3 disease, they were randomized to TME surgery alone, and this TME was quality control where the surgeon had to get training done for the TME. They had to be mentored for the TME and to make sure the quality of the surgery was as required. And the other arm was pre-operative radiation therapy followed by surgery. And as you can see, the local recurrence went down significantly. In the previous trial, the local recurrence rate were more like 25 to 30%. In the TME era, the numbers were like 11%. Radiation did improve the local control rate, but the absolute difference was small. And there was no difference in overall survival. On subset analysis, they noticed that in stage 3 disease, the local recurrence rate, even with TME, was about 18%, which was brought down to less than 50% by adding radiation therapy. But again, radiation comes at a cost. There were more wound complication, more post-operative leaks requiring additional intervention. So the adjuvant trials demonstrated chemo-RT improves survival. If pre-operative radiation therapy is better than post-operative radiation therapy, and this question was answered by these two clinical trials. The MRC, which compared short course of pre-operative radiation therapy to selective post-op chemo-RT, and the German rectal trial, which basically established pre-operative chemoradiation therapy as standard of care in North America. So if you look at the MRC trial, what they did was, the one arm got pre-operative radiation therapy to 25 grain 5 fraction, followed by surgery. The other arm got TME surgery, followed by selective post-op chemo-RT only if the margin was positive. What they noticed that this selective approach of just limiting post-op radiation therapy to margin positive was not the optimal approach, because the local recurrence rate in that group was about 11%. And similarly, the disease-free survival was also inferior. The local recurrence rate in the pre-op group was only 4% with a better disease-free survival. There is no difference in overall survival. Thereby establishing that if you have to do treatment, pre-op is a better approach than post-op because of better local control and better disease-free survival. But the trial which basically established pre-op chemoradiation therapy as standard of care was the German rectal trial. It's a large trial of about 800 patients, T3, T4 disease, and positive. 2 arms. The first arm was the post-op arm where everybody got TME followed by chemoradiation therapy. You can see the dose of radiation therapy was about 10% higher in the post-op group, 55.8 versus 50.4. But adjuvant chemotherapy was very similar. And what the study showed that the local recurrence rate in the pre-op arm was significantly inferior, significantly better in comparison to post-op, 10% versus 7.1%. Number of patients in the pre-op arm who could have sphincter sparing surgery was significantly higher. There were about 50% improvement in sphincter sparing surgery, 20% in the pre-op group versus 39% in the post-op group. So another advantage of pre-op radiation therapy was downsizing, making disease suitable for sphincter sparing surgery. Look at the complication rate. There was both acute and the late complication was significantly less in the pre-operative group. The acute diarrhea, acute any grade 3 complication was significantly less in pre-operative group, 27 versus 40%. And if you look at the long-term complication, the most common one is the stricture formation. It was 3 times less in the pre-op group versus the post-op group. So the pre-op group had fewer acute complication, fewer late complication. The only downside of the pre-op treatment was over-treatment. As alluded that when you do this pre-op treatment, you use endoscopic ultrasound or pelvic MRI for staging, and about 15 to 20% of the people are overstaged, even though you think they are T3, T4 disease, but at surgery they are found to have T1, T2 disease. So one downside of pre-operative treatment is over-treatment for a subset of people. But the fact that the local control is better, there is more sphincter sparing surgery feasible, and less acute and chronic complication, all 4 advantages overcome the disadvantage of over-treatment. So the pre-operative treatment advantages: more compliance, lower acute and chronic side effects, better downstaging which makes sphincter sparing surgery feasible, and better local control. And the only downside is over-treatment. So based on these 4 or 5 potential advantages, this has been established as standard of care for neoadjuvant chemoradiation therapy for locally advanced rectal cancer. Now, we discuss about the pre-operative regimen. There are the two regimens which are used all across the world. One is 25 Gray and 5 fraction based on the Swedish data, or the protracted one, 45 to 50.4 Gray, with concurrent chemotherapy followed by surgery. The short course is more cost effective and more convenient to the patient, but the long course you can combine with chemo, so you can have more downsizing, you have better likelihood of sphincter preservation, and maybe better functional outcome because of conventional fractionation. The first randomized trial comparing the short course to the long course was from the Polish group, about 300 patients. The short course was pre-op 25 Gray and 5 fractions followed by surgery, and the long course was a standard 50.4 Gray with 5FU and leucovorin followed by surgery. And you can see the trial was, even though it was not powered to see the difference, they did not see any difference in local recurrence rate or overall survival, and noticed less acute toxicity with the short course of treatment. At the same time, a similar study was initiated by the TROG group, which again compared the similar regimen, pre-op 25 Gray and 5 fractions, followed by surgery, followed by adjuvant chemotherapy, or chemoradiation therapy followed by surgery, followed by adjuvant chemotherapy. And if you look at the results of the trial, when the local recurrence rate appeared to be a bit higher in the short treatment, even though it was not statistically significant. On subset analysis, what they noticed that if you have low-lying rectal cancer, then the local recurrence rate was significantly higher with the short course, suggesting that there is the importance of downsizing, which is you don't get with short course of treatment. There was no difference in overall survival, and the grade 3 complications were comparable. The criticism of the study was it was not powered for the equivalence, and the data which shows no difference or a difference favoring long course is hard to interpret, and we need longer follow-up. So in summary, the standard of care for locally advanced rectal cancer is neoadjuvant chemoradiation therapy with 5FU plus 50.4 Gray radiation therapy. Nowadays, instead of 5FU, one can use oral capecitabine. People have done randomized trial comparing 5FU plus oxaliplatinum with radiation therapy, but the studies have not shown no difference in outcome and more acute toxicity. So the standard of care is chemoradiation therapy with 5FU or 5FU analog of capecitabine with radiation, followed by TME surgery. And when we do radiation therapy treatment, the terminology which we use is CTV. So we include the entire rectum, presacral nodes, internal iliac nodes, and the low common iliac nodes, and tumor with a margin with the mesorectum. So basically, we take the PTV1 to 45 Gray to 25 fraction, and this volume with the margin is taken to 50.4 Gray and 28 fraction. And this is how the beam arrangement looks like. Patient is in prone position, CT simulation, prone to remove the small intestine outside the treatment volume. Most commonly 3-field technique, 2 lateral and 1 posterior field. And this is how the portal looks like for the 3D conformed radiation therapy. This way you can reduce the dose of critical organs and still cover the target adequately to improve the tolerance and improve the outcome and response rate. Thank you.
I think what we're going to do is maybe we should change to the coffee break relatively, because we've been behind because of the lights being up, and then we can continue the discussion later on, since the coffees are available, I think. Yeah. So we might as well, instead of taking 15 minutes, we should do it like 5 minutes break, since we're behind. I guess we should just go ahead and start, and I'm still finding that there are still people lining up. My next topic will be on adjuvant treatment of colorectal cancer. As you know, when we talk about adjuvant colorectal cancer, giving adjuvant therapy for colorectal cancer, we basically are talking about stage 2 and 3. As you know, stage 1 has a good prognosis, and stage 4 is already metastatic. So if you look at the survival curve, you find that stage 1 has a very good survival, but at the same time, if you look at stage 3C, which has a very dismal survival at 25%. Naturally, we have to figure out who should be getting adjuvant therapy. So we consider patients with high-risk stage 2 and stage 3 to be getting adjuvant therapy. The low-risk stage 2, however, has been controversial. I can discuss that later on. So what constitute high-risk stage 2? Those are the people with fully differentiated histology, lymphatic tumor that has lymphatic invasion or vascular invasion, and it's with the bowel obstruction, and also have perineural invasion, localized perforation, and if the margin is positive. Now, I didn't mention the lymph nodes earlier. So we have to have removed at least 12 lymph nodes removed. That to say that it is adequately removed and resected out. In Europe, I think they consider 10 lymph nodes as the criteria. The reason why we say that we need to look at the number of lymph node removed is there's one study that says, like, if you remove 1 to 10 lymph nodes only, you have 67% 5-year survival, and also 56% almost what you call 8-year survival. But if you remove more than 4 lymph nodes, you have almost like 90% 5-year survival just by removing the lymph node. Nobody really exactly know the mechanism. Some think that this is basically allow us to do better staging, evaluation, and define better treatment. But I think there is a lot more than that. So before we give the adjuvant therapy, what are the tests we need to do to have it as a baseline? We need to have a CEA, particularly if the patient has a CEA that's high before. We need to have CT scan of the abdomen, pelvis, and the chest with contrast. And if some patients cannot take the CT scan, we should do the MRI of the abdomen and pelvis. And in rectal cancer, if we can do rectal endoscopic ultrasound, it's really nice because we can get a good sense of how the tumor is, where the tumor is. PET-CT is not routinely indicated, but if you have a questionable CT or MRI finding, we need to do that. And of course, if there's stage 2, we always like to have microsatellite stability analysis because that gives us whether we need to give chemotherapy or not chemotherapy. Of course, we have to understand the limitation of PET-CT. CT is not a substitute for the for the regular CT scan with contrast because it is lower resolution compared to the regular CT. And PET may not pick up lesions that are smaller than 1 centimeter. And we have to also be cautious about interpreting these lung lesions in the infection endemic area, like here, where we have tuberculosis and pneumonia, because they can also give positive finding on PET-CT. For example, there was a study that showed sensitivity is 89% and specificity is only 61% in regions with endemic infectious lung disease compared to almost 80% in the regions that we don't have the endemic lung disease. This is a sample of the endoscopic ultrasound. This is the probe, and you see that this is a tumor here, and it's passing beyond submucosa and also passing almost like passing the muscularis propria and almost to the subserosa area. So that will give us basically the stage of that rectal tumor, and that can define what treatment we should be giving. And CEA, of course, we need to know CEA, and I'm sure a lot of people understand that. But it's a glycosylated cell surface with a molecular weight of 180,000 daltons. The lower limit of normal range is 2 and then 5. But we have to be cautious about elevated CEA because elevated CEA can be seen in smokers and in patients with chronic inflammatory disease. But they're not that high. However, the one that we have to be cautious is they can be high also in other cancers like lung, breast, GYN, and other GI cancers. So it is not useful, what the CEA is not useful to do diagnosis and screening of colorectal cancer. However, it is a reliable marker for disease recurrence if it is initially elevated. So that's a way to follow CEA. There is the percentage of patient with elevated CEA, you can see by stage. Like on stage 1, the elevated CEA is only 4%, but on stage 4, you see that is significantly higher at 65%. So going back to adjuvant therapy, just go briefly to the history of adjuvant therapy. We used to give 5-FU only, but it doesn't have any results, effective results. And somewhere along the line, somebody noticed that the medication that we used to deworm the animals and later on to the humans, I don't know how they get to look into that drug. I'm still curious about how they get that. It's supposed to show the immunostimulatory effect. So they did a study adding 5-FU and levamisole, and that shows an improved survival in stage 3 cancer. So we started using that combination regimen as the treatment at that time. However, the biggest problem with that drug is that it has significant side effects, particularly nausea, vomiting, and bloated feeling, and really uncomfortable with this. And recently, it was found to have encephalopathy, so it was withdrawn from the market. At the same time, another group of investigators looking into 5-FU leucovorin as a way of treating using as an adjuvant therapy. As you know, 5-FU inhibits amygdalase synthesis that is necessary for DNA's formation, and they found that reduced folate inside the cell will increase the sensitivity to 5-FU. So folinic acid is a formal derivative of tetrahydrofolic acid, and once inside the cell, they transform into reduced folate. That gives the 5-FU significantly more effective. So with that concept in mind, they started using 5-FU leucovorin compared to observation, and they found that there's an increase in survival of 83% compared to 78% with the observation only. However, the problem with 5-FU at that time was we were giving bolus 5-FU, and it causes significant toxicity, particularly diarrhea and granulocytosis. So another group of investigators led by a physician named de Gramont used the infusion of 5-FU, and he compared that to bolus 5-FU, and he found that, in fact, infusion of 5-FU is equally effective, but more importantly, it has less toxicity, particularly granulocytopenia. So that regimen, we call it the Gramont regimen, has become popular, and I think we're still using that. Again, the same investigators started adding oxaliplatin into that regimen, and they found that when they use the oxaliplatin, it increases the survival from here to the, and that is statistically significant. However, what they also found is that they did find that in stage 2, it increases the survival, but it is not statistically significant. So at that point, we recommend that adjuvant chemotherapy should be given only to stage 3. Then this mosaic regimen came out, and that study confirmed that giving oxaliplatin, adding oxaliplatin to 5-FU leucovorin definitely is improving, and we started using that as a standard regimen at this point. And this is FOLFOX regimen that includes oxaliplatin, is leucovorin, and 5-FU, and 400 and 600, and at the same time we give oxaliplatin of 85 milligrams every 2 weeks. We give it for 12 cycles, about 6 months of it. The interesting thing about oxaliplatin, however, it is a third-generation platinum. It has less GI, auto, and nephrotoxicity, and it also doesn't cause pancytopenia like carboplatin. However, as a single agent, it only has 5% response. So as a single agent, it's totally ineffective. But when it adds to 5-FU, it potentiates the effect of 5-FU. So oxaliplatin should always be given with 5-FU. Then the big problem with oxaliplatin is the neurotoxicity. There are two types of neurotoxicity. That's acute hypersensitivity type of neurotoxicity and chronic polyneuropathy. Acute hypersensitivity type of neuropathy occurs immediately during the treatment or after treatment, and it's induced by cold. So a lot of time when you give the treatment with oxaliplatin, we always advise the patient not to go into cold weather or go into the refrigerator, or in fact, we even advise drinking against ice water or any ice drink because it will trigger bronchospasm and can be dangerous, scary, because we had one patient like that and we didn't even know how to manage it. Fortunately, the patient recovered. So chronic polyneuropathy, however, is different. It occurs in only 15% of the patient, and it's glove and stocking type, and it's cumulative. And that's become a big problem recently because it continues to, it develops after continued exposure of the oxaliplatin, and so we have to stop once we see this, stop oxaliplatin once we see signs of neuropathy in the patients. And somebody else came out with capecitabine, and that is an oral drug, so it is very convenient. And it is a prodrug of 5-DFUR, which is converted to 5-FU. So it's actually an active metabolic drug that changes to active component once it's inside a cell. And it's also found that it has better survival than 5-FU leucovorin. The main problem is it has a side effect called hand-foot syndrome, where we have to monitor that and have to readjust the dose. Dosage of 1250 milligram per meter square, but that usually is a regimen that's used in Europe, and we found that if people don't tolerate that dose that much, we usually end up starting at 1,000 milligram per meter square. Now, this is a picture of hand-foot syndrome. This is grade 2 hand-foot syndrome. You see that it's shining palms and sole of feet. People will complain of burning sensation in the palm and the feet, and we have to continue to monitor that. If it gets beyond stage 2, we have to basically readjust the capecitabine. Of course, the problem is not all regimen works, and FOLFIRI, for example, is a regimen that replaces oxaliplatin with irinotecan, and it's equally effective in metastatic carcinoma. However, we found that it doesn't work at all in adjuvant setting. The same is true with bevacizumab, which is the VEGF inhibitor. You know, when we add that drug to FOLFOX, we found that it's more effective in increased survival in metastatic carcinoma. But it doesn't show to be the same in the adjuvant setting. Tyrosine kinase inhibitors like cetuximab and panitumumab so far it's controversial. Couple of data show that they work, and couple of data show no. So there's a large randomized style trial going on, looking into that drug, particularly in those people with KRAS wild type people. Currently, radiation is not indicated in colon cancer unless it is perforated or adhered to adjacent organs, or has abscess formation, or if the margin is positive. So if we get a clean margin, we don't normally give radiation therapy to colon cancer. Now, the problem is stage 2 colon cancer. It has 20% recurrence rate, and all these studies that we have done so far show that it is improved the recurrence rate, but unfortunately, it never reaches the statistical significance to really justify self-giving the treatment. And theoretically, it's only improved like 2 to 4%. But in high risk stage 2, it occurs more than 5%. The big thing is if they have the microsatellite instability significantly high, we found that it has better prognosis. And this is basically explaining what the DNA mismatch repair or microsatellite instability is. Here we have this short segment of DNA that is mismatched. It should be either GC or TA. And instead, it was not matched properly. So you have these mismatch repair protein that comes in and fix that and repair it to become normal. But if one of the genes become mutated and the the protein is deficient, we see this loss of mismatch repair function. And so you start accumulating. And this short segment of DNA that is not mismatched is being thrown away and discarded. And that we measure as microsatellite test. And here, for example, I'm sure that Dr. Tan has already shown it. This is a MLH1 positive. And here we have this patient is MSH2 negative. And here you have negative finding, and here we have positive finding. And with the PCR on polymerase chain reaction on the tumor DNA, you see the normal pattern, and this is the abnormal when you start seeing microsatellite instabilities in the high. The interesting thing is that if you have microsatellite instability high, the prognosis is relatively very good compared to people who get either microsatellite stability or low frequency or microsatellite instability. And that's one of the things that we see in stage 2, that if they have MSI high, they have good prognosis. The interesting also is that if they have MSI high, they don't respond well to 5-FU at all. And so here, for example, these patients are the patients with microsatellite instability high, but these patients are the one that was given with 5-FU. You see the percentage alive drop down. So we consider when you have MSI high, they are resistant to 5-FU, and that's one of the reasons why we need to have microsatellite instability tests on these people with stage 2. So we talk about rectal cancer, and I found that Dr. Chody and Dr. Verawal have discussed some. The rectal cancer, we have problem with rectal cancer is because we have a risk of a local recurrence due to absence of serosa surrounding the rectum and close proximity of the rectum to the other organs to make it difficult for surgery. And of course, we also have technical difficulty to get wide surgical margin, a clean resection. And so we found that stage 2 and stage 3 rectal cancer has very high local relapse and risk of metastasis. And so we feel that to control this thing, we will need to have combined chemotherapy and radiation therapy to control local recurrence at the same time controlling the distant metastasis. But the problem is, when do we give them? And one of the things we found is that if we give neoadjuvant therapy, combining chemotherapy and radiation therapy before surgery, it is usually given because what we found is that a lot of time when the staging was done before the surgery, they always turned out to be understaging. So at the surgery, it tends to be higher than what the workup shows. And they also found preoperative chemoradiation therapy to be better than postoperative radiation therapy. And here's the study that looked into that. This is the incident local recurrence rate, and you found that postoperative chemotherapy has 13% local recurrence rate, and preoperative chemoradiation therapy has only 6% recurrence rate. The same was true with distal recurrence. The postoperative have 36%, and preoperative have 38%. Actually, it's the opposite. Preoperative have a lower recurrence rate. And that's the advantage of the preoperative chemotherapy, is downstaging the tumor and make it much more effective for radiation therapy to be given. And it also avoids radiation-induced injury, because with the surgery you can have adhesions and all the stuff, and that can be in the way of the radiation field. It also increased the number of patients that can take the full dose of the chemotherapy. And of course, we can also control the micrometastasis before it becomes macrometastasis. So the only problem is that, as Dr. Very well mentioned, that the preoperative chemoradiation therapies, we may be over-treating some in early stage tumor. But this is the regimen we most of the time use: 5-FU leucovorin combined with radiation therapy for surgery, and then followed by adjuvant chemotherapy, which usually is FOLFOX, or capecitabine plus radiation therapy followed by surgery and adjuvant chemotherapy. The interesting thing we have to think about is that if the patient has uses what you call sensitive hand, a patient already had diabetic neuropathy, or if the patient has his professional work includes like musician that needs delicate fingers, we don't give oxaliplatin. We will try to give FOLFIRI in that setting. But although, like I said, the adjuvant setting with FOLFIRI is not that effective. So the interesting thing is, when we did give the preoperative chemotherapy and radiation, we found that we can downstage 50 to 60% of the time, and 20% of the time it went to complete remission. And in stage 1, in fact, 40 to 50% will go into complete remission. And in one study, 5-year recurrence rate, free survival rates were 90.5%. If it is complete remission, if there is only poor response, there's only 58.5%. But this is the interesting study. I don't know if Dr. Chudi will agree or not, but this was a study presented last January, just a month ago, at the ASCO GI meeting, that they found that when you give the chemotherapy, preoperative chemo and radiation, it causes complete remission, 40 to 50% case in stage 1 and 30 to 40% complete remission. And what they found is that people who got complete remission, who did not have surgery, have and only after chemoradiation therapy, have 91% 4-year survival compared to people who have the neoadjuvant chemoradiation plus surgery. So there's some suggestion that we may be able to do just watch and wait after chemoradiation therapy before we consider doing any surgery at all. I think, but then this is just a more or less like a retrospective study, and so we need to confirm that down the line. So how do we follow up? We need to follow up every 3 to 6 months with history and physical, and every 6 months for a total of 5 years, CEA 2 to 3 months for 2 years, then every 6 months for a total of 5 years, and CT scan of the abdomen, pelvis annually, and chest annually for up to 5 years, colonoscopy in 3 to 6 months, if not done yet, and if it is done, to do colonoscopy again 1 year, and if that's, then you repeat it in 3 years. So in summary, I just want to say that stage 3 and stage 2, we do give adjuvant chemotherapy, the colon. Low-grade stage 2 is controversial. Like I said, if the patient has MSI high, we don't give the adjuvant chemotherapy. But if the patient is in MSI low, we try to give adjuvant chemotherapy based on the patient's condition. And usually adjuvant therapy is given for 6 months. If there's neuropathy, like I said, or the person uses delicate hand as part of his profession, we try not to give oxaliplatin. And in the rectal cancer, we will give neoadjuvant chemotherapy followed with radiation therapy before surgery. Thank you. So at this point, I would like to invite Dr. Fred Smith. I don't know what happened with the projector again. There's no power. Okay. Dr. Smith will discuss the management of metastatic carcinoma. Dr. Smith has the clinical appointment as clinical associate professor at Georgetown, and also at the assistant professor at Hopkins. And if you think of it, he has been to. Actually, I don't know if he has 25% Burmese blood. He was born in Burma and left the country when he was like 9th grade.
So, as Dr. Myotan said, I was born and raised here. Presentation, which I will share. Yeah, when you hear me, don't speak English. I'll understand. So for my non-Burmese speaking colleagues, I just explained that I was born and raised here, and I still speak the language with but with a great accent that almost no one understands. It's very nice to learn. But I warned them that if they didn't like my presentation, they shouldn't, speak near me and criticize my presentation, otherwise I'd be hurt. So with that, thank you very much. I am honored to be here. When the issue of the more important tasks of infectious disease, tuberculosis, malaria, HIV is declining. Diseases of developed countries, coronary artery disease and cancer emerge. And one of the things about colorectal cancer, if you look at the global map, is that it's a disease of increased incidence in well-developed countries. This may be dietary, it may be many factors, as Dr. Leotard has said. But what I learned in a survey that was done was perhaps because of the resource organization that Dr. Sohn is so sensitive to, that more cases are presented in advanced stage in this country. So my charge is to talk about the role of treating metastatic colon cancer. And although I feel like I'm not an expert without my slides, I'm going to continue. And hopefully
I think we need to change
so
that.
as Dr. Chodhi said, colorectal, is this better? Colorectal cancer is still about the third leading cause of cancer mortality in both American women and men. The concern is that when they present with metastatic disease, in the past we felt that there was very little chance to cure them, but now with multimodality, combined thinking, combined approach, there is a higher potential of cure even in individuals, as Dr. Chodhi has pointed out, with metastatic disease to the liver and with metastatic disease also to the lung. So metastatic disease then is stage 4 cancer. And this is one where traditionally surgical cure, which is still the only primary way of curing this disease, is not possible. We then attend to systemic therapy. Here we go. Thank you. So how do I advance, Mio? So this is a patient who is a 57-year-old woman who presented with significant abdominal pain and was obstructed and had to be taken quickly to surgery. Otherwise, we would have presented her in a group to discuss what to do. So she had an obstructive lesion in the left colon, which was resected. There were 19 nodes removed, but one was positive for cancer. Postoperatively, we get PET CT, and I'm not sure if you can see it. Do you have the pointer? I'm not sure if you can see it, but there's a small lesion on the liver. And on the PET, it lights up. But again, with resource limitation, you really don't need the PET. A good reading would have shown that to be malignant. It is solitary. So this patient had a liver biopsy. And as Dr. Tan pointed out, the patient had mucin production, CK20 positive. This is metastatic disease in the liver. Is she curable? I think so. And partly it's done because of the combined, so this is the patient's colon lesion, same histology as in the liver. So I'm going to pass over some of these slides. Why treat metastatic disease that cannot be cured surgically, even if there is a potential for no longer resecting liver metastases or lung metastases? One is because it's been shown time and again in studies that there is an improvement in survival, and as Dr. Chodhi showed you, as we've improved our treatments, there's prolongation of survival now to years, and that the quality of life of patients with metastatic disease treated do better than those who are left without treatment. So a brief history of chemotherapy then, Dr. Mio has talked about 5-FU. Initially, we gave it just by bolus. That's not as effective as infusional chemotherapy, but then the resources that you need a pump. And although there are portable pumps, they're not that convenient. So capecitabine is an oral medication that has very similar pharmacodynamics to infusional 5-FU, and I would propose that that be considered, more resource appropriate. With the advent of irinotecan and oxaliplatin, these regimens called FOLFIRI and FOLFOX have increased the response rate, the time to progression, and the survival of patients with metastatic disease. The problem, again, is that you need an infusion pump. There's clear evidence, I think, that Xelox, where capecitabine, also called Xeloda, is substituted for the infusional 5-FU, used with oxaliplatin and less frequently with irinotecan, leads to the same benefit. So this, I would propose, might be a more reasonable treatment. Now, of the past decade, the excitement has been of anti-vascular endothelial growth factor and also of anti-EGFR treatments. So I won't dwell on this too much, other than to show you that when compared using leucovorin 5-FU to adding additional drugs, there's been significant, fairly consistently significant improvement in time to progression and survival. And this is just, again, to show that if one adds irinotecan or FOLFOX, there is a good median survival. Now, in our situation, we have shown that adding vascular endothelial inhibitors like bevacizumab, Avastin, will substantially improve the response and the survival in patients with metastatic colon cancer. Hasn't helped in adjuvant disease, but in metastatic disease, I'll show you some data to demonstrate that. There are other, anti-VEGF and anti-EGFR, some of which are pills that are coming along that have added to our armamentarium, our way of being able to manage these diseases. Dr. Mio has already shown you this molecule of the immunomonoclonal antibody bevacizumab, and how it works is by reducing the proliferation of neovascularization that the cancer has, which may impede, actually, ingress of chemotherapy into the cancer. Now, the EGFR is a different receptor, and the way that cetuximab works is by blocking the dimerization, which, if left unimpeded, instructs the nucleus to survive, to proliferate, and to metastasize. The problem with it is that about 25% of colon cancers will have this KRAS mutation. And Dr. Tan has pointed out that she will sometimes measure the KRAS mutation. If that's the case, cetuximab is, first of all, the KRAS mutated cancers are more aggressive. And secondly, they don't allow for cetuximab to interfere with the pathway. They're already on autopilot to continue that. So these next couple of slides are just summaries of the contribution of bevacizumab to chemotherapy. Without bevacizumab, with bevacizumab, about a 5-month improvement in survival, and that's been shown fairly standardly across the board. And these are just a compilation of other studies, again showing that adding the VEGF inhibitor bevacizumab adds to this. Studies with EGFR inhibition, not quite standard because in the beginning the KRAS mutation was not recognized. And consequently, if you give EGFR inhibitor to KRAS mutated patients, no help. Using both even in the KRAS wild type, has now been shown not to contribute anything but toxicity and expense. So we don't do that. So there are other drugs coming in the advent of metastatic colon treatment, so that now, in the beginning when I started taking care of patients with malignant disease, we only had 5-FU. And all of a sudden, we have leucovorin 5-FU, we have capecitabine, we have Folfox, we have Folfiri, we have Avastin Folfox, bevacizumab Folfiri, cetuximab, and even more are coming. There's a pill, regorafenib, which will sustain stability, although not improve necessarily response rate. And there are more to come. So again, in trying to think about resource limitation, I think that when we get together in our group, when we encounter a patient with metastatic disease, the first thing, as Dr. Chody pointed out, is even when they have metastatic disease, are they potentially resectable? And if so, the timing of chemotherapy versus surgery is discussed, and then the choice of drug is used. If they are not resectable, in other words, there is really no chance of resection for cure, one thing that always comes up for us is clinical trials. We're not curing the majority of these patients. We're trying, nonetheless, to palliate and improve their quality of life and survival. If there is an interesting clinical trial, we will then recruit our patient to participate in that. And thank you very much.
I think what we're going to do now is we're going to discuss tumor boards, since the speakers have all done for this particular disease. What I like to do is I like to invite the faculty to come up here and sit. Dr. Suong, Dr. Tan, Dr. Chody, Dr. Berrywell, and Dr. Smith, and Dr. Wang. Please come up. What is going to happen, right now we're going to present a couple of cases as a sample, and then you now use the clicker. Is it what function?
Yes.
Okay. As I mentioned, you use the clicker, and there will be a couple of questions that's going to pop up. Like I said, we're not really basically testing your knowledge. We're just trying to see how people treat here so that we can have the understanding of what we can discuss in the future about how to approach this disease. And then, if we have, what I'm trying to do is like a relatively quick and this discussion, and we will, if you have any cases in regards to cancer that you would like to discuss or present, like I said, as educational value or for management, please do so. This is all open, and we would like everybody to participate in the discussion, because the cases that we have, that I'm presenting here for colorectal, are actual cases that we did at my institution. So that doesn't mean that they agree with my institution approach. Hello? And it's basically my fellows' approach. So that doesn't mean that they will agree. So this would be what I'm thinking of, is trying to see how people approach the disease. And like I said, there's so much controversy in a lot of the disease management that we need to do it. Charlie, would you come up here and be a moderator? Doug, can I get... No. I can't find the... Which one? I can't find the cursor, and I have to get out of that.
So, unlike Dr. Smith, I don't speak Burmese, but I will... I think the one word I've learned this morning is Mingalaba. Is that right? I've used my one word now. I'm done. So I'm Charlie Penley. I'm a medical oncologist in Tennessee. I'm a community doctor like many of you. And one of the things we do in our hospital every Wednesday morning is we have a gathering where we have new cases that are brought by our surgical colleagues, our primary care physicians, the radiation oncology colleagues, and we come together in a conference room around a table and we talk about the cases. And I hope that you all have the opportunity to do that, but I think that really that really reinforces the concept that oncology is a team sport. We very rarely operate alone. And so these cases, and I'm not at all familiar with the cases, nor am I familiar with the cases on Wednesday mornings at my hospital, so this is not at all unusual. But so we'll start with this one, a 50-year-old man who presents with shortness of breath on exertion. He's been having weakness and he fatigues easily for the past month. He has a history of coronary artery disease, and you can see that he's had stents. He has a family history with colon cancer, and you see that he is a bit tachycardic. He looks to be ill. His performance status is 2, and he is anemic. His hematocrit's 29%, with an MCV that's low, suggesting iron deficiency or chronic blood loss, slightly decreased platelet count, and an LDH that is a bit elevated. And so to advance the slides, we do this one. So this is a question for the clickers. You have them in your hands. So what do you do now? Do you test his stool for occult blood? Do you order a CAT scan? You order a barium minima, or you call a cardiologist? You know, when all else fails, you ask for another specialist, right? You ask for another doctor to help out. So use your clickers now, and then I guess someone is going to tabulate the results.
So use your clickers.
And we'll just do this for a few seconds, and then we'll move on. You won't get a grade at the end of the conference.
Sorry, now you go.
Okay, do them again. We'll make this work.
Okay.
Okay, so here we're going to get the results, I think. Doug says that most of us will do a stool test for occult blood. I think that's reasonable. But the next step then will be to go further with his evaluation. You see that his stool is positive. His iron level, based on his serum ferritin, is very low. His iron and TIBC levels are iron is low, TIBC is high. The percent saturation is borderline low, if I remembered my values correctly. So what's the next step? Here's another clicker question. Do you refer for endoscopy or colonoscopy? Do you order a barium minima, or do you order a CT scan? Doug, you're going to have to operate this because I don't know how. And so use your clickers now, if you will. And the survey says, here we go. And this is exactly what I would do in my medical center at home. You have the GI tract evaluated. Now, we've got, I don't know where it's appropriate to engage our colleagues at the tables here. Should we just work through the case and then we'll talk about the management? Okay, so we have a colonoscopy done by a gastroenterologist. It shows a large mass obstructing or nearly obstructing at the level of the hepatic flexure, and a biopsy, as we heard earlier this morning, is positive, probably for a well to moderately well-differentiated adenocarcinoma. So this is very common wherever you are. And so this is the next, the question is about the next test, a CT scan, a CEA, a surgical consultation, a PET scan, or all of the above. And I think that there are multiple possible answers there. So we'll use your clickers now, please. Okay. We all hit our buttons. I expect we'll see, well, so all of the above. Some would refer immediately to a surgeon. Some would order a CT scan. I think all of these things are appropriate. And in my community, and I bet it's the same here, the timing will dictate the order of these things. The availability of a CT scan, the availability of a surgeon to see your patient. I can do the blood test in my office. The PET scan, I understand you all don't have access to PET scans here yet, although in speaking with one of the diagnostic radiologists, I understand that that's very near. Within 4 to 6 months, I'm told, PET scans will be available here. So PET scans are useful but not mandatory. And so this patient would need many, or if not all of these diagnostic.
May I comment, Charlie?
I'm sorry, please.
I would say, though, that in that I would not recommend a PET scan at this stage. Doing the 3 makes sense, the CEA, the consult, and the colonoscopy, or I think there was added colonoscopy. But I think there's really limited role this early on to do a PET scan in this case, and I would say that's a wrong answer.
Well, I think you're right, and I think PET scans are useful in some circumstances, but with early stage colon rectal cancer, probably not so useful. So we have a CT scan showing a big mass in his transverse colon with some low density mesenteric nodes, but no evidence of disseminated disease. The CEA level is moderately elevated at 26. And here is a picture for our pathologist to look at and give us a quick read. But I think this represents an adenocarcinoma.
Yes, I agree with you. Yeah, well, it does show some normal mucosa at the left field, and then you see the tumor that consists of very closely packed glands, and on the surface you do make out the presence of some papillary structures. So it's moderately differentiated adenocarcinoma.
Good. See, I think our pathologist brings the same slide to the conference every week because they know they can confuse me. I'm easily confused I didn't do so well in pathology in medical school. So it's a moderately differentiated adenocarcinoma, and it appears that there must have been a surgical procedure here, and we have 48 regional nodes removed and 1 positive. So as we heard a little earlier, that is I guess that's a T3 or T2 or 3 in 1 lesion. And here is the staging. And, oops, sorry. So the stage, here's your question. Hit the clickers on this one, and Doug will tabulate this. And I can't remember the depth of invasion there. I don't think it was transmural, was it? I didn't think so.
Well, the image didn't really show the full thickness, but it did
look
like it was invading the muscularis propria at least.
So this group is saying CA, and I agree with you. Hope we all agree. And then here's a slide representing survival. Sorry? And so after surgery, this patient has stage 3A disease. Well, when do you repeat the CEA to see if it's coming down, to see if it's normalized? This is a good question because I'm not sure I know the answer to this. So we'll use your clickers now, if you would. And the group generally says 4 to 8 weeks post-op. And I can't remember the serum half-life of CEA. I'm sure that it's clearly the half-life is significant, and so ordering it too soon, you wouldn't get a valid answer. So here we go. 4 weeks later, it's 3. It's come down to normal range. And then this is a question about post-operative chemotherapy. For those of you, I think there were some medical oncologists in the room, and we've just heard a talk about adjuvant chemotherapy. So what would be a reasonable choice for post-operative adjuvant chemotherapy in this patient? There you see the choices, and so use your clickers, please. Whoops. Don't give it away, Doug. So what do we have the results? Oh, there you go. And so this means that Dr. Anil Thant gave a nice lecture, and everybody's in agreement there.
How old was the patient?
I don't remember. 50. So a young, otherwise pretty healthy man, except he had...
Is there ever any role for monotherapy in a patient who's that age for adjuvant therapy? In the adjuvant, let's say a piano player or a violin player or something like that, would you ever go with monotherapy? I mean, just to have a little discussion here.
FOLFIRI is questionable effectiveness as an adjuvant. I don't know what you...
I think that's a very good question, and the other would be to use capecitabine. There is advantage to adding oxaliplatin. You do get a bump in your control rate, but when you look at it with a patient maybe who has other morbidities, who has other illnesses, or who has other interest, I think capecitabine is a very reasonable choice.
And I don't know if it was mentioned in the talk, if I can, what's the status of the ongoing studies comparing 3 months to 6 months of FOLFOX? Because a concern is the cumulative toxicity, and I think that's going to have a big impact if indeed that's a positive study. Where are we now with those trials?
That is a study that we're conducting in the United States. Initially, because of our fear of cancer, we tended to, I think, overtreat. And then it's hard in our country to just, in the U.S., because I consider Myanmar my country as well. But it's hard to back off. So unless we do a clinical trial, it's hard to back off. So there's a clinical trial comparing just 3 months to 6 months. In addition, they are randomizing, Dr. Mio had talked about using celecoxib, Celebrex, to try to protect from colon cancer. So there's a randomization between 6 versus 3 months, and another randomization between Celebrex and placebo, still ongoing.
Yeah, one of the problems is that FOLFOX, we have not been able to finish all 12 cycles most of the time. And like I said, because of the neuropathy, we end up stopping it somewhere around after about 3 months or so. So basically, that's a big reason. And in fact, we continue with 5-year leucovorin after 3 months or so because the patients can't tolerate the neuropathy. I don't know if is that true in Singapore?
I think that would be true. I mean, I think that a lot of times near the end of the 6 months, I mean, we're dropping or significantly reducing the dose of oxaliplatin, both because of neuropathy and sometimes because of myelosuppression as well. So I think that the majority of our patients don't see the full doses of oxaliplatin all the way through.
I think it's a shame that we don't have the microphone from the audience. I don't know if anybody
Clearly,
have a difference in opinion regarding the
comments,
treatment.
please raise your hand so we can, and we really want this to be
Discussion.
interactive.
This is not discussion among here. It's going to be, it should be discussion
So please,
among everybody.
Speak up and we'll try to get a microphone to you.
Yeah, just raise your hand and I think they will come and give you the, okay, there is a,
But I do think that the whole issue of able to complete 6 months of FOLFOX is a real one, and in my practice as well, we have difficulty with the neuropathy. And it's not so much the acute cold sensitivity. We've learned how to coach people around that, but it's that chronic polyneuropathy that really becomes incapacitating in some patients. So we have a question over here.
Okay, so this is a minor point for the primary care and general medicine physicians in the audience. I was just wondering in this setting about the utility of doing a fecal occult blood test before referring straight for a colonoscopy. I mean, the patient is obviously symptomatic from anemia, and so the fecal occult blood would not be like a preventative screening. It would be a test for what is the cause of this anemia. And the most likely in a male patient of this age is a GI bleed. So, you know, fecal occult blood tests are cheap and quick, but it's still, you know, it's a small procedure, and just what is the utility of doing a fecal occult blood in this setting rather than referring straight for a colonoscopy?
Well, I agree with you. In this particular patient, I don't think anybody would have taken a negative fecal occult blood test and stopped there. I mean, I think everyone would have seen those values and referred the patient for colonoscopy. So it's quick and easy, and it's part of, when I trained, it was sort of part of the routine physical examination. It's become less commonly used now, and so I think it certainly doesn't add to the cost of caring for the patient, but it's another piece of data that you can get. Any other thoughts about that? So this patient went on to have adjuvant chemotherapy. The standard in the U.S. is FOLFOX currently, and we talked about the difficulties there. And so we have another patient. By the way, any other questions from out there about this patient? So we'll move to our second case, which is a 74-year-old man, this time more comorbid conditions: congestive heart failure, diabetes, mild pre-existing peripheral neuropathy. He was found to have a stage 3 colon cancer. His exam was pretty unremarkable. He had a pretty functional performance status, had normal hematologic parameters with normal CT scan, and it says patient refuses treatment. You know, and frankly, at age 74, some would argue that that's reasonable, although 74-year-old patients with good health, underlying health, would typically be treated in the U.S. with stage 3 colon cancer. But in a patient that's otherwise ill, it might be a reasonable decision. So the question here is, what do you do with this patient who's had surgically resected stage 3 colon cancer, and how do you follow him? So there are the options, and why don't you go ahead and use your clickers, and we'll see what individuals think about that.
That's great. I think that's too hard.
Okay, so we'll see what the audience thinks. So we have CEAs as the most common choice, all of the above second most common, and I'd be interested to hear what other members of the panel think about this, but I think in this case, in my opinion, it depends on what you would do with a positive finding if you found it. If this man is really, really ill and not highly functional, and if you found a rise in his CEA, or if you found a new lesion on his CT scan, or if you found his liver function studies were abnormal, would you act on that information? And if you're not going to act on that information, then I wouldn't do any of them. But I think that if you think there's a possibility of finding a small oligometastatic lesion, then it might be reasonable to do these things and screen for it. And in fact, the standard of care, according to all the guidelines in patients that have treated and potentially cured colon cancer, is to do annual CT scans and serial CTs or CEAs and all those things. But if this patient's functional capabilities are low enough that you might not consider a surgical resection of a metastatic lesion or something like that, I'm not sure I'd do any of it. So I'd be interested to know what other people on the panel think.
So one of the concerns that I would like to propose with the CEA is that it's not always elevated with metastatic colon cancer. About 20% of the time it'll be normal. So I would propose that may not be the best to follow this patient. But thereafter, I think it's not just a matter of what we would do, but also what the patient would allow us to do. And the other concern there is that someone initially at this stage might say, I don't want anything. But if you confront them and say, look, the only way to keep you alive for 3 more years is to resect that solitary lesion in the liver, they might change their minds. So I think that those all have to be kept in mind, but I think probably I would agree with all of the above. Unless the patient is so troubled that their chance of living, remember, still the #1 cause of death, at least in the US, is coronary artery disease. So if their life expectancy is less than 3 years with their coronary artery disease, then maybe you do nothing.
Any comments or thoughts from the audience?
I agree with that answer because from the surgeon's point of view, the 74 years is not a very old age because we operated if the diagnosis free up to the 85 or 86 years old. He is the physiologically, the withstand the effects of anesthesia and surgery. But in that case, I agree because he has the CCF in the past. Thanks.
Thank you for those comments. I think you're right. It's more than chronologic age. It's physiologic age and functional capabilities and performance status. And I think all those things play a role in your decision making. I'm not sure what this slide is supposed to be.
That's still supposed to be colorectal.
Can help us. This was maybe just...
Again, you may have to forgive me in the sense that I have all these colorectal cancer, but I'm not a pathologist, so I'm just putting those, and I couldn't figure out which patient was what.
Okay, so let's maybe move to the third patient. Okay, so this
that's patient, the same patient.
Oh, same patient. I'm sorry. Being followed with serial CT and CEAs and gets a colonoscopy annually. By the way, I'm not sure any of us would do a CT scan every 3 months. I would not in my practice. I don't know if others would or not. I think that's probably too frequent. So now it's 2 years later. And 2 years later, this patient now has weakness and decreased appetite, and you see here some abnormal liver function tests and a CEA that's now remarkably elevated at 293 micrograms per liter, and has a CT PET. Probably doesn't need the PET, but we'll see what the images show. And
that's a PET.
And I think what you I have a pointer here, but I think what we see
the one on the right. I don't know. Dr.
The CT shows some sort of heterogeneity of the liver here, and the PET shows focal abnormalities in the parenchyma of the liver. That would be my non-radiologist reading of that. Is that?
This kind of shows multiple levels.
Oh, we have a diagnostic radiologist in the audience. Would you agree with that, sir?
By looking at these two images now, I don't think this is very diagnostic. By looking the CT scan, only one image there, and the hypodensity, as you mentioned, as you show up to this area, could be any artifact coming from the ribs. So one image is not enough for diagnosis purpose. I cannot comment on this one now.
Okay.
But on the other hand now, if we do the PET scan, we always have three orthogonal images, axial, coronal, and sagittal images, so that you can correlate the actual anatomy. Because this is not a fusion PET CT, this is just a PET scan alone. So it is very difficult, in axial images to localize the exact anatomy, where the lesion is. Now, even by looking at this one, I don't know, the level of the section. I saw this little shadow there, triangular shape, which is the liver there, but the intensity of the object is quite homogeneous. So by looking at this one, this liver, I think this is just the normal uptake in the liver. Because by looking at this one, this, I call it a hot spot, hypermetabolic, and this one is an intermediate, and this is a background activity. There are three different activities there. So by looking at this one, if I see the activity in the same as a liver, because I don't have the SUV value here mentioned there, that means that standard value uptake is not mentioned here. So if I have a choice to looking these three intensity, if there's any lesion similar to the liver intensity, I will say this is indeterminate. And it is this intensity is a background activity, and this is the hypermetabolic, that is a positive activity there. But by looking at this one, I don't know what these two structures are.
I think those are probably in the renal pelvis, I would guess.
This could be a kidney. So I don't know exactly the anatomy, the area of abnormality there.
I think maybe those images weren't perhaps the most convincing.
Right.
But with more images, I'm sure that obviously you rarely get a scan with a single image, right? You get multiple images, so you get multiple opportunities. And one of the lessons I learned about radiology when I was an internal medicine resident back in the 1980s is I would go and look at the most obvious thing, and our radiologist said, no, you've got to look at everything. You can't just look at the most obvious. You have to look at all the images. That's why we take every one of those pictures. So anyway, the conclusion with more than one image was that this did represent metastatic disease in the liver. And the liver biopsy was positive for metastatic disease, wild-type KRAS, and that'll play a role maybe in therapeutic decision-making. And our next slide here is interactive slide. So metastatic colon cancer documented by biopsy. The patient now says, I'm willing to consider therapy. And the question for the audience with the clickers is, which regimen do you think is most reasonable in a man with metastatic adenocarcinoma? Remember, wild-type KRAS.
I think we've got a clicker for them.
So use your clickers, and then we'll get the response, and then we'll turn it to Dr. Smith to discuss that, since he just gave us that talk.
I think that the responses are actually quite correct. If resources are not a problem, I would choose number 1 or number 2, because there is contribution of about 5 to 6 months median improvement in survival with minimal, albeit some added toxicity. But in a climate where, the resources are limited, I think this is not a patient that we're going to cure. So capecitabine is also a very acceptable answer.
May I just make a comment? First of all, I think that to just say multiple bilateral, this could be resectable disease. This patient has been inadequately assessed for resectability. And so I think that's the first step, is to just on a non-contrast PET is woefully inadequate to assess resectability, and then just jump to chemotherapy. I think the whole message, is that we should think about this as a multidisciplinary process in which one needs to fully evaluate. I also think there's no role for a liver biopsy here. KRAS is concordant with the primary tumor, so if you're concerned about wanting to know the RAS status, you can use the primary tumor. This is obvious metastatic disease in the liver with a CEA of 300 and a positive PET scan. There's no role for doing a liver biopsy. So I would suggest first is better cross-sectional imaging to assess resectability. Bilateral disease is not a contraindication. Multiple could be 3, could be 6, it still could be resectable. And that could have a very different, even in a 74-year-old, could have a very different management. So I think the message has to be pretty clear, not just to jump into this, rushing right to chemotherapy.
So you don't consider 74 as an age limit for resectability?
That's right. I mean, it just depends. I'm just saying, though, the message needs to be, it's likely unresectable disease, but we haven't even seen, we just said bilateral, let's move on to chemo. We need to think about going through the steps to exclude resectability before we jump to that conclusion.
So this is what we're talking about. These are actual cases, and these are the cases selected by my, treated by my fellows. So these are the choices that they took. So you now see that Dr. Chody doesn't agree with that. So
Can I make another point, which is that, the sort of assessment of resectability is very important because it influenced the kind of chemotherapy we would give. This patient is borderline resectable. We would be potentially more aggressive, with combination chemotherapy with targeted agents to get the patient, make the patient resectable, versus if we're going down a purely palliative route, where in a minimally symptomatic patient, we may be going with capecitabine, as a good choice for this patient. So I think that the resectability issue has to be addressed at the beginning, not only because it influenced the choice of chemotherapeutic agents as well.
I think all the points are well taken. It's crucial to have the complete picture before you make therapeutic decisions. And we only showed a representative image there from the CT PET. I have to assume that there was a more thorough evaluation, and it was reasonable to assume that it was unresectable. But I'm assuming that only because of the slides that I'm given. But I agree with your points.
Another thing, would you go with first-line cetuximab in a wild-type patient?
Well, which one? Panitumumab? Oh, no,
yeah, you said Avastin or. So, Fred, or all of you, you give the option for number 1 to include an EGF receptor inhibitor first line let's say it was clearly unresectable patient. Is that common practice to do that?
If it's a resectable patient, we would still use the FOLFOX aggressive. I don't think we would use panitumumab. No.
So the points that were made were very well taken. That's, again, why we always have a group meeting with surgeons, etc. Several oncologists sometimes differing in opinion. If the patient's going to go to resection, you want to avoid Avastin perhaps in the beginning because of the anti-angiogenic effect on surgery. To Dr. Chody's question, there has been a clinical trial that compared in the wild type FOLFOX Avastin or FOLFIRI Avastin versus FOLFOX cetuximab or FOLFIRI cetuximab. And there's been controversy, but the debate is that they're at least equal. And there is one study called the FIRE study that suggests that the cetuximab in the wild type might have a small advantage. And since we can, we use them sequentially. If we use cetuximab first, later on we'll use Avastin, or vice versa. So I think they're both reasonable.
I think we can go to treatment.
Okay, so let's move on to the next slide, unless there are comments from the audience. So the patient receives capecitabine, gets a nice response documented by improvement in the CEA and liver enzymes and doing well on therapy for 4 months. He is seen for follow-up, and I'm assuming that means that these 4 months are off therapy, and is seen for follow-up, asymptomatic, feeling well, and his CEA has risen from 11 up to 69. And so the question with the clickers is, what do we do next? And you see the choices there, and we'll see what you all say. So it appears that the majority would repeat the PET-CT as opposed to a CT scan alone, and I'll be interested to hear some discussion about that, because in my mind, in this situation, monitoring metastatic disease, I'm not sure serial PET scans are terribly helpful. Serial CT might give you a better indication of change in tumor size or tumor volume, or to start different chemotherapy, such as panitumumab or cetuximab as single agents. So I'd be interested to hear from the panel or from the audience. These are not quite so clear cut, maybe in this case. Fred?
Any comment?
Any comments from our audience? We have the microphone here, please.
I agree pretty much doing the PET-CT scan rather than doing only the CT scan, because in the latest generation in PET-CT, we're using the diagnostic, normal dose CT. That means that if we order PET-CT, we do, both, fusion PET-CT as well as the diagnosed CT on the same setting without moving the patient there. So by doing that, I got the CT, full dose, the regular CT with all 3 orthogonal images like, hexachromal sagittal. All the images just like exactly the same as the CT scan. Those images I got. In addition, I got the PET. That means that if I see something, a nodule or mass, then I correlate with the PET scan. Well, this nodule or mass is hypermetabolic. So at the same time in my report, I can tell that, oh, this is the mass is growing, and the SUV, that means that the activity is also rising. So you get, both information, anatomy, anatomic, information, as well as the physiologic, the information by doing the PET-CT.
So I agree. In general, you get a little more information. I'll tell you that in the U.S., for example, Medicare won't pay for serial PET scans. They'll pay for serial CT monitoring over time. And so it depends a little bit on where you practice and what the resources are, but I think you get a bit of additional information with the PET, but I think for monitoring purposes, most of the time we get enough information with PET, or with CT, excuse me. So the patient actually, with the rise in CEA, and it doesn't say whether the imaging was done, I suspect there probably was some imaging, because most of the time we won't start a new regimen without having a new baseline, a new set of images to help guide our assessment of response. And so it started on panitumumab, which is the anti-VEGF drug that we heard about, and so develops a pruritic rash all over the body after 1 dose. This is just an image indicating the rash, and I can tell you from my practice, this is a relatively mild rash with panitumumab. I don't know how much experience there is in the audience using that agent, but it's typically an acneiform rash, head, face, and upper torso, and it can be, you can have these horrible acneiform pustules. This is a mild to moderate reaction. And so how do you manage the rash? I don't know, this is an interesting question. I don't think we've talked about this, but that's certainly one of the major toxicities of panitumumab. So this is a clicker question. How do you manage this rash? This is the most common response here is option 2, applying the hydrocortisone cream topically plus or minus topical clindamycin. Fred, that's your choice. It's how we would manage it in my clinic, and I would assume that's pretty universal.
having have a look at this rash, does it connote any efficacy for the drug, like in alatinib? If you give alatinib and if the patient comes out with a minor rash, it seems it means that it's more efficacious than those patients who do not have rash at all.
So that's an excellent question. In lung cancer, there's a correlation with gemcitabine and erlotinib and the development of a rash and clinical improvement. With these EGFR inhibitors, there appears not to be that correlation, and it appears to be a fairly universal, it's a matter of degree, reaction. Almost everyone seems to get the reaction. That's why, perhaps in relationship to Dr. Choudhury's earlier question, these EGFR inhibitors are a little bit more difficult to tolerate than the bevacizumab, and there's a slant towards giving bevacizumab more. Particularly, we have to watch out for, between cetuximab and panitumumab, cetuximab is a partial humanized antibody. So you can have severe anaphylactic infusional reactions. You have to be very careful with that. Panitumumab is a totally humanized, it's a totally human monoclonal antibody, so you have less reaction. But Dr. Song, I don't think that it correlates. I think it's a class effect. Almost everyone will get some rash with these.
So, can I just comment?
In fact, I'll just say, that reminds me, I misspoke. I said VEGF. It is an EGFR inhibitor, not a bit.
Can I just comment? So this patient responded to first-line single-agent capecitabine, and then I guess progressed on single-agent capecitabine, and you went to an EGF receptor inhibitor. Why not go oxaliplatin, FOLFIRI, something, another different cytotoxic than going right to panitumumab without even using any of the other combination and not even bevacizumab? Just your thought process and why you went with panitumumab.
I think based primarily because of his age.
And he, if I remember correctly, he had
I think they have a concern about that.
Pre-existing neuropathy, I think, and that was the reason.
But we can still use FOLFIRI in a sense. But the thing is, my thinking is that they were concerned about age, so they decided to go less aggressive approach. Because if you look at it, even with the they just give the capecitabine instead of using FOLFOX or FOLFIRI at that time, which was probably better to use then than later on.
If you stopped the cape and then you got progression, you would just start back on the same agent. You wouldn't add panitumumab, would you? In other words, was the capecitabine stopped when there was progression, or was you progressed while on single agent?
Yeah, no, there was progression while on capecitabine. In metastatic, theoretically, we try not to stop anymore.
So then the question, so with this relatively mild to moderate rash, we've treated it topically, and what do we do now? We've had one infusion of panitumumab. What do we do now? And this is another quicker question. Do we continue it? Do we hold it and restart it at a lower dose, or do we stop it completely? Make your choices, please. And I think this is a question of severity in my experience. If it is relatively mild, I simply continue it with topical preparations for the rash. If it is a more severe reaction, and I think that's probably what we were trying to portray here, you hold it until it gets to grade 2 or less, and then resume it, and you can use dose reductions along with the topical measures. And it all depends, in my experience, on the severity as assessed primarily by the patient. Some of them look pretty awful, and the patient seems to be tolerating it well, and sometimes very minor-looking things seem to make people miserable. So I think a lot of it depends on how the patient is tolerating it. So here's another case. I don't know how many more we have. A 41-year-old man admitted with rectal bleeding. I'm sorry?
Just one question.
Oh, sure.
One more question.
If you decide on the patient's reactions, would you stop or do not stop if the patient does not feel uncomfortable at all? The patient has a pretty severe rash, by the way it looks, but the patient does not feel any severe discomfort. Would you stop it or not stop it?
I'll probably hold it for to let the rash subside a bit, and then restart it a little bit.
Usually we hold it, we have this grade for the rash, so we hold it until it gets down to grade 1, at that point restart it again. And if you restart, and if the patient gets that severe rash again, you restart at lower dose, and that's when we stop benitumab. We don't push it anymore.
So Dawn Stefanik is part of our panel, and she's going to talk about some of these factors. Do you want to comment now, Dawn?
No,
she's
that's fine.
Okay. She's fighting jet lag, but so I totally agree.
I think she can discuss it at her site.
We have done what you guys just said. If we have a mild rash, they'll start the topical creams and things and see how the patient does. And if they're not having any discomfort or anything, they'll continue. But as you said, if it gets worse, I mean, that was very mild to me too. I mean, we've seen people who have the rash on their face that look like they're a teenager with just full-blown acne, I mean, everywhere. And then at times that'll get bad and some of the pustules will open and they'll weep. And then at that time we have to, you know, do the treatment, stop, wait till it subsides, and then we'll go back and reduce the dose usually, and then restart.
So the next case, 41-year-old male with rectal bleeding, so wake up radiation oncologist here, especially jet-lagged ones. He has some nausea and near syncope and was found to be anemic. He had a colonoscopy showing a large, friable, nearly obstructing tumor in the ascending colon. Okay. All right, so I was wrong on that. Biopsy showed an adenocarcinoma in the ascending colon with a CT of the chest, abdomen, and pelvis demonstrating a sub-centimeter regional lymph node, but no distant metastasis. Here you see the labs. Primarily notice the anemia with a still well-preserved MCV, suggesting that the blood loss was acute, normal platelet count, and I believe normal liver function studies and normal BU and creatinine. So a laparoscopic assisted hemicolectomy was performed with a loop ileostomy. And here's our pathology.
Again, it is not the right sequence, but please read it.
Well, it's malignant glands, and you can see that they're all very architecturally distorted and abnormal. So in keeping with an adenocarcinoma.
No, it was rectal bleeding. I misspoke. I was assuming by the first sentence that this was going to be a rectal cancer.
Right, that's true.
There you go, it's making assumptions. But anyway, it's an ascending colon lesion. Pathology showed a well to moderately well-differentiated adenocarcinoma with lymphovascular perineural invasion invading through the muscularis propria into pericolonic tissue, but not to the serosa, and 7 out of 36 regional nodes were involved. Surgical margins were negative. So this is a stage 3C lesion with the TNM staging that you see there. And the question here is, should microsatellite instability test and DNA mismatch repair enzyme levels be done on that patient? You have two choices. The stage 3, wait, don't hit your clickers just yet. Are we ready, Doug?
It's not working for that question.
Okay. So we'll skip that question. Sorry about that. Well, yeah, maybe a show of hands. And I don't know how commonly this is done here by the pathologists. I know that we heard from Singapore that's done fairly routinely. What is the standard here with MSH testing? It is not done here routinely? Okay. So, and I'm not sure, frankly, I think this is more important in terms of ascertaining whether or not this might be a Lynch syndrome patient, but it's not terribly important in terms of determining therapy.
I voted for no because this MSI stability is more useful in case of stage 2 disease where you decide to give or not to give chemotherapy. Depending on the MSI level, if it is stage 4, if MSI low, you will give chemotherapy, high, you will give.
I think because the patient is 41-year-old.
I think the reason to do it here is not to determine the treatment for this patient, but to determine if this patient might be part of a familial syndrome, and that's the reason to do it in this patient. And so what you see here is that there's 2 that are positive, 2 that are negative, if I read that correctly.
MLH1 is negative, and BMS2 is negative.
And here is the the specifics of the testing. Neil, would you like to say anything?
Just to show the PCR findings of what that means.
And so what does that mean? And so this is the question for the clickers, if we can get that to work. So does that affect your choice of therapy? Does it affect other things? So please make your choices. So here is the group response. About 40% said the patient and the family need genetic counseling, and 40% said all the above. I don't know that the genetic testing helped me determine that the patient needed adjuvant chemotherapy. I think the stage of the disease helped me make that decision, but the genetic testing certainly suggests that, or the MSH testing certainly suggests that the patient may be part of a familial kindred that's affected by Lynch syndrome or one of those and need genetic counseling. Neil, would you like to?
No, what I would do is I would take all of the, only because the stage 3 being the stage 3, I'll give adjuvant therapy, and there is a possibility that may be hereditary.
The other point is if this was suspected or known prior to surgery, the other is that this patient that could have benefited by a subtotal colectomy rather than just a right hemicolectomy. Now, saying that a stage 3C, this patient's got a bigger problem than a new cancer 10 years from now, given the high risk of recurrence. But still, that's another take-home point, is that one needs to think about in a young patient initially, to think about that prior to, unless it's an emergency operation, that it would have been warranted to consider, even in a young patient without any testing, a subtotal colectomy rather than just a right hemicolectomy.
So, why do you think you want to do subtotal? Will there be a benefit on that one, or you just do hemicolectomy and can't you do colonoscopy and keep follow-up?
No, in the patient, particularly if it's an earlier stage cancer, this patient has still is going to need probably annual colonoscopy, and so the recommendation is to do, in fact, at least for an earlier stage cancer. Again, a very advanced aggressive cancer like this may be different, but generally one would consider a subtotal colectomy and then surveillance with just sigmoidoscopy. You don't need full prep, you don't need sedation and so forth, and so that generally the guidelines would be to do a subtotal colectomy in an HNPCC or Lynch syndrome patient specifically, assuming that's what it is.
Only one more thing I want to add is there are 4 genes involved with HNPCC, even though the risk of colorectal cancer is about 80%, but the PMS2 has the least penetrance. So if you look at the recent data, the people with PMS2 microsatellite instability, the risk of colorectal cancer is only 20%. So people need to individualize care based on which gene is involved. It's like in past we treat everybody with HNPCC with the same hammer, but I think the risk and incidence is different based on what gene is involved.
We do have, we're going to end up maybe we change that to.
So we have one more case that we'll do, and then I think we're going to break perhaps for lunch. This is a 67-year-old man presenting with diarrhea that's occasionally bloody, with a 30-pound weight loss over 4 months' time. Has colonoscopy demonstrating a near obstructing mass 10 centimeters from the anal verge, and a biopsy confirms adenocarcinoma. You see that he is moderately anemic with normal renal function, a CEA that's elevated at 30, with CT scans that are done and not endorectal ultrasound. And here is a picture of his pathology slide.
Well, this looks like just a biopsy because it's all fragmented in smaller piece, and you can see the normal colonic mucosa on the left field, and deep to the colonic mucosa, within where you expect the submucosa to be, are these abnormal glands that are scattered amongst stroma that has got some degree of inflammation. Thanks very much for pointing those malignant glands. You've been paying attention during pathology descriptions.
Here is his CT, or a representative image from the CT.
That seems to be okay, I think.
Don't know that we can see much there.
That's supposed to be PET. It's not really good, clean one, but I think we just get that.
So the CT is said to show no evidence of metastasis, but does demonstrate some colon wall thickening at the rectosigmoid junction. And so what is the next step? Here we ask your clicker use again. So it appears that over half of you said low anterior resection, about a third said AP resection, and less than 10% said a diverting ostomy. Dr. Chody, would you like to comment?
So was there any staging of the T stage? So no EUS, no pelvic?
No EUS, no.
So the first step would have been something to assess whether this is a intermediate stage. And if that's the case, then you're thinking, and no metastatic, you're thinking of a curative intent paradigm. So you're thinking neoadjuvant chemorads as the, but here you've got question is the near obstructing. And the question is near, just because the scope can't go through doesn't mean if the patient was still not emergent, then I don't think a diverting colostomy is necessarily needed. One can just go right to, typically if the bowels are still moving, chemoradiation, and likely you'll get a fairly quick response. More and more now, if you have a totally obstructed patient, we'll go to, who's curable, we'll go to a stent rather than a diverting ostomy. But I think here, assuming you're thinking of a bulky tumor, you're going to be thinking chemoradiation. If I had to choose one of these, that would be number 3. But frankly, none of those I would choose.
And I think in my medical center, more patients would get a diverting ostomy than anything else if they were clinically nearly obstructed. I agree with you. If they're still moving their bowels, they're not nauseated, vomiting. I can't remember if there was nausea here, but if there was not any evidence of a bowel obstruction, then most people would treat them with chemotherapy and radiation therapy, because many times those obstructing symptoms will improve pretty rapidly with the radiation therapy and the infusional 5FU.
The staging should be done first, which could involve either EUS or pelvic MRI, depending on the expertise available, to define TNM staging. And if it is T3 and above, then the plan would be to do neoadjuvant chemoradiation therapy rather than do any one of the 3.
What if it's a country like Myanmar where we don't have EUS? Well, will you consider that enough staging done, or do you still try to figure out how to determine what stage that is?
I think at least use contrast with that. That CT had no contrast, so I mean, at least a CT with contrast, the cross-section of the pelvis will give you at least a clue whether this is something that, I mean, it doesn't sound like it could be a T1 or T2 cancer given the symptoms, so I guess you could go right to neoadjuvant chemoradiation without any further staging, but you definitely need at least a good CT scan here. It's also unusual to have a CEA of 30 with localized disease, so I'd be still already very worried about metastatic disease, and that CT was not a good enough quality to really rule out metastatic disease. So you may also consider, I mean, I'm very anti-PET. I think we over-pushed PET here, but you could make a role for a PET CT here, both to stage for a high CEA and a negative CT scan, and some use it for rectal cancer to stage response, so there could be a role for PET.
And I agree with Mike Chody and Sushiberi on saying that this patient deserves further staging investigations and determine which state is he or she is in. And in our country, since we haven't got any facility to investigate the exact stage of the disease, they usually end up having surgery like this before complete staging being done. And I, for one, would prefer to have these patients empirically to go for neoadjuvant therapy, seeing the overt clinical stage.
And like one can use the old system. If you do an exam and you can feel the mass, if the mass is fixed, that tells you the patient needs neoadjuvant, irrespective of what the endoscopic ultrasound or pelvic MRI shows.
Yeah, so for very many years we didn't have endoscopic ultrasound at my facility, and we would have done the very best CT imaging that we could, and probably diverted this patient if they were symptomatic, and then treated them with radiation therapy and chemotherapy. So he has a diverting colostomy, and what's the next step? I've been sort of getting ahead of myself here. So here are the options for you. Please use your clickers right now. Doug and I are a team. I promise you we don't do this regularly, as you can probably tell.
It'd be nice.
While we're voting, just another comment. Diverting ileostomy would be the preferred operation if you're going to divert, not a diverting colostomy.
So the majority of you all would choose option number 3. In fact, all of you all would choose option number 3. Anybody on the panel disagree with that? Okay, that was the only unanimous vote that we've had so far. And so they do go on to get neoadjuvant capecitabine and radiation therapy before surgery. And I think that's the next case. So let's maybe stop for lunch at this point because of time.
Yeah, we so basically behind time. You know what we can do is done. I think we can get a session after the lunch break. So why don't we have a lunch break at this point? It will be downstairs on the first floor in the Brazili room. Am I right? Ground floor. On the ground floor. Okay. So that will be lunch, and we can resume after the lunch is done. We will have about roughly 40 minutes. No, yeah, 15 minutes or so of lunch time.